Well, thanks, Betty. It's great to be here to have this opportunity to meet with you to talk about what we do in the interRAI research group and how it may be helpful to you in your various jobs. I think if you can glean something from Betty's introduction, one thing is that we're a very persistent group. It took about 6 years from the day that Betty and I met in that lonely hallway to the RAI home care getting mandated, but we sort of stuck with it. And I think what's interesting is if you look at over that 15-year time period where we've come in terms of Canada as a country and health information about vulnerable populations, it's really quite astounding. I just published a paper called The Iron Lungs of Gerontology. It's about the future of nursing homes in Canada. It was a paper I was invited to do by the Canadian Journal on Aging. In 1986, my then PhD supervisor, Bill Forbes, wrote a book about institutionalization of the elderly in Canada, and he talked about what direction long-term care should be going. At that time, the only information we had available about elderly people in nursing homes, let alone home care, was how old they were, what their sex was, a little bit of diagnostic information. But even estimating the percentage of people in nursing homes in the country was quite difficult. The only clinical information we had for the entire country was a single study done in Saskatoon with 600 people in nursing homes in that region where they had a little bit of information on physical disability. That was it in terms of what we knew about nursing homes in Canada at the time. And what was interesting is he made the argument that we need to change the role of nursing homes in the country to change from just being a place that's an end destination for older people. And he drew an analogy to the polio epidemic and said, well, if we hadn't looked at treatment of polio, and we sort of focused on making better iron lungs, we would have had more comfortable, stylish iron lungs, but we wouldn't have done anything about polio in the end. And he made the argument that nursing homes bear the risk of becoming the iron lungs of gerontology. Well, in that paper, we were able to show data from 8 provinces and territories, giving very rich information about who's in nursing homes and what they look like, and made the argument that, in fact, there's lots that long-term care homes could do to change its role from being simply a place, a terminal destination where people go to wait for the end of their lives, to a part of the healthcare system that intervenes to change people's lives and, in some cases, return people back to the community. Home care was pretty much in the same situation. We probably had less information about home care because it's hard to know what home care is today, let alone in 1986, where there were very different models of home care across the country, and the development of home care as a sector was much more embryonic in nature, and so there were no data to be had whatsoever. And what I'll show you today is what it looks like 25 years later. Our problem today isn't so much getting more data. We're now in the phase that we need to think about how to use the evidence we have more effectively, and how we need to start to make healthcare work as a system using the clinical information we have from the interRAI instruments. So we're getting close to being at the point where, for most of the sectors in Ontario that health and social services serve, we have good quality, generally interRAI assessment systems in place. So the days of no data are soon to be behind us. Now we need to figure out, okay, how do CCACs and long-term care homes and hospitals and community support services and family doctors work together to make use of this clinical information to really change people's lives and to help at the system level to really plan how the system works together. So what I'm going to do today is give you a bit of a taste of different applications for these instruments. I'll also introduce you a little bit to who and what interRAI is about. But because we do have a fair bit of time, I'd like to take a fairly relaxed pace with this and have you guys interrupt and ask questions. Also, if you want to go off in a totally different direction from what I've prepared, if you name a topic, I've probably done a talk on it in the last 6 months. I can get it off my computer, so feel free to sort of redirect the discussion as you see fit. As a starting point, though, I'd like to sort of see a show of hands. How many of you have never heard of interRAI before? This is the first time you've heard of us. Okay, so on. How many of you have actually seen, how many of you used the RAI-HC assessment? Okay, and then everybody else, would you sort of describe yourselves as sort of beginner to medium level of knowledge? I don't want to make too many assumptions about where you're at. It'll be very easy with this stuff to get lost in technical details. So the challenge now that we face within the interRAI group is that we can use the information for so many purposes where newer audiences are going to kind of be overwhelming sometimes. So if I'm getting too jargony or technical, don't be shy about interrupting, and I'll clarify as we go along. All right, so here are the things I thought we could do. One, to just give you a quick background of what's happened in Canada in terms of the adoption of the different interRAI instruments, and then I'll also focus specifically on what this means for you folks here in Erie St. Clair. And then I thought we could highlight 4 different kinds of research projects. One very large project that's done that is directly relevant to issues of resource allocation related to home care and long-term care as well, but I'll highlight the home care results. Another is a large project that's underway that is focusing on an important subpopulation, people with neurological conditions. In part, what these slides show is the power that we have to understand rare populations, but it also gets to the point of, can we be sure that this information system that we put in place for a general population also works for more specialized populations with complex needs. Next, to talk about something new that's coming your way, the interRAI palliative care, and some research that's been done around that instrument, and then something that must happen, and hasn't happened yet in terms of research, but is a definite direction that we in the interRAI group are working toward in partnership with the World Health Organization. And I also want to sort of give some thoughts, if we have time at the end, about what I've seen in the last 4.5 years in my capacity as a home care research and knowledge exchange chair, and what I think is left to be done in terms of future directions for the sector in general, and also with whoever takes over, if there still is a home care chair in the next fiscal year. Okay, so interRAI, what we are is we're a bunch of professors and clinicians. So there's 60 of us from 32 countries around the world. We're actually organized as a not-for-profit research network, so we have a corporate structure. I'm on the board of directors, and we did that so that we could own the intellectual property to our instruments, maintain international standards for them, and make them available to countries around the world in order to do that, because otherwise these things can sort of morph into 100 different variants, and very quickly you lose standards with it. Through the interRAI organization, we are also, as researchers, able to access data for research purposes. So the typical thing we do when we create an instrument, as we have done in Canada, is we give away the right to use the instrument free of charge. So CIHI and the ministry don't pay interRAI anything to use the RAI home care, the RAI long-term care, the new palliative care instrument, and so on. But we get in exchange our de-identified data for research purposes. So all of our funding in interRAI, or the large majority, about 95%, comes from research grants that we're able to pursue in either developing new instruments or using data from these instruments. So what we do as a group is we focus on creating new assessment instruments and refining the existing ones that we have. And we're really interested in complicated populations. We don't so much care about people who have pretty straightforward health needs. A 21-year-old with appendicitis, you don't have to be a rocket scientist to figure out what has to be done. It's pretty routine medicine. But somebody who's 80 years old and has heart failure and diabetes and dementia, that's a complicated person. Somebody who's dying, somebody who has mental health needs, somebody with a physical or intellectual disability, those are all really complicated folks. And what makes them complicated is not just a single diagnosis that affects their experience, but it's the interaction of their medical condition, and there's usually multiple medical conditions going on, their psychological well-being, their social environment, economic factors, and a variety of other factors all interact to make the answer of what help this person needs much more complex than a 21-year-old with appendicitis. So that's what we're interested in. And what we want to do is create instruments that address the person's strengths, preferences, and needs. And part of the way we do this is by measuring specific issues that affect a person's life. So we measure things like signs of depressive symptoms, physical functioning, medical conditions, poverty, you name it. We measure those things, and that's easily identified as part of the needs. And there are items in our instruments, particularly in our newer instruments, that also flag strengths that the person has. But the preferences part is really one that comes out of how the instruments are used. And so what we develop aren't just forms for people to fill out, but they're approaches to assessment and care planning that we need to enact. And I think that's one of the areas, if I was to look at how we're doing in Canada, we're not doing quite as well. And what I mean by that is that once you've done the assessment, you're only one step into the process. You now need to engage the person and the family in a conversation about, well, here's what we found. Now, which of these are your priorities? And of these things that you didn't mention as a priority, are you sure you don't really want to do anything about this? And what would be your approach to how you'd like to deal with this? So it's not a fill out the form, tell the person what you're going to prescribe for them, and you're done. There's a very strong interactive component where you bring the person and family into the assessment. And I think that's one of the areas, if I was to editorialize as we go, that I think we could do a better job in Canada in general on that piece. So how we do our research is through all these through very large multinational collaborative efforts. So we gather these data through these research agreements, and we can do cross-national comparative research. So there's things we can learn about our country by doing comparisons across different jurisdictions and within jurisdictions. But we also have access to some of the best expertise in the world through the interRAI research network. So some of our members have won very prestigious awards. Harriet Finsaveri has been named Woman of the Year, Physician of the Year in Finland. She's one of the people that comes to all of our meetings and bears down on all of the interRAI instruments and its applications. So that's the caliber of person that we can collaborate with internationally in doing this. But also by working with people from different countries, you learn things from those different countries that you may not have understood before, and it helps you to reflect in a more informed way about how your own country is doing certain things. Now, the other thing I'd say is it's not just about creating forms, but we put more emphasis on how we use the information. And so I'll get to that in a moment. But it's not just about filling something out, but thinking about how to use it for personal services, but also as a management function, a planning function, and so on. So these are the countries that are represented in the interRAI group. There's 7 Canadian members now within interRAI. We also have members in the United States. You can't really tell the differentiation. The darker blue text is where we have formal members in that country. The lighter blue text, which is kind of hard to see, the difference here are countries where we're doing research, we don't yet have a formal member yet. So there's 32 countries, Canada, the US, and North America. In Europe, we go from Iceland to Finland. All the Nordic countries represented, several former East Bloc countries, most of the Western European countries. In Japan, we have members from, in the Pacific Rim, from Japan through to Singapore and Israel, and sort of India and Israel and Lebanon in the Middle East, and members in Brazil and Chile and South America. So what's interesting about this mixture is that they're obviously different culturally, lots of variations there. That helps us in a country that is very multicultural in its nature. So that we have members from China, Japan, India, Latin America. Those are all major cultural minorities in the Canadian context, and it helps us to address the question, well, I know that it may work with a general, 7th generation Canadian audience. What about new immigrants from this country? Well, most of those countries are well represented in the interRAI context, and we know that our assessments work well in Hong Kong, so chances are it'll work pretty well in Chinatown and in Toronto. So that's one benefit. The other thing, though, is that you see there's real differences in these countries in terms of how their healthcare system is structured. Some are very hierarchical in nature, some are very broad-based, more egalitarian in terms of the relationship between physicians and other health professionals. Some are have more emphasis on facility-based care, others are more on community-based care. There's young societies, old societies, privatized healthcare systems, more publicly funded healthcare systems. All those differences lead to natural policy experiments that you can start to exploit as data start to build up. In doing that, we need to be sure that we can be confident that the information from these assessments means the same thing from country to country. And so one of the things that we do with that is careful back translations of our assessment instruments. And when we do those back translations, we realize sometimes the concepts that we thought were clear aren't quite as clear as we imagined. So with the back translation of the home care instrument to the original Japanese, the issue came up with, well, how do you deal with somebody who wears a kimono instead of traditional Western clothing when you're coding the ADL for dressing? So we had to scratch our heads and figure this out for a while. I was involved in back translation of the Dutch instrument, where the item on surgical pain was translated as pain from a cut. Well, it's not really the same thing. Surgical pain is a different kind of pain than just having cut your finger. Our colleagues in Sweden, sort of when they did the back translation on the nursing home instrument that participates in activities programs, saw that the initial translation in Swedish was participates in gymnastics. Well, not a lot of long-term care home residents are involved in gymnastics, so they managed to correct that. All that stuff is tedious, but it's critical, because what it means is that we can be sure that when we look at Canadian data, we compare it to another country's data, that we're sure that it means the same thing. And we also need to be able to have that confidence within our own country. So one of the other things that our group does is a lot of work on interRAI reliability testing. And we do that cross-nationally to be sure that the instruments are reliable across different jurisdictions. So there's several papers that we've done that are like 11 and 12 country reliability studies that let us be confident that we're measuring things in a consistent way across these jurisdictions. This is the family of instruments that we've created. In the home care setting, we have instruments for comprehensive assessment of home care clients, as well as the interRAI contact assessment, which is used as a brief screener for people coming into the home care context. Instruments for nursing homes and complex continuum care. We have a new instrument for acute care, including an emergency department screener. That's basically the same as the interRAI contact assessment. We've just finished a large 9-country study, I believe, with the emergency department screener. The acute care instrument is probably, if I was to sort of look over the next 5 years, it's one of the gaps that we don't have an interRAI instrument used on a large scale yet in the acute care sector in Canada, and I think this is one that's probably makes a lot of sense to start to think about. So particularly if we're interested in ALC patients, with the ED screener and the contact assessment, we can identify people likely to become ALC patients very early on. And with those folks, if they're admitted to an acute bed, we can start with the interRAI acute care, start to manage them much more effectively than we're doing so far in acute setting. There are care planning protocols attached to it, quality indicators attached to it. So that's one of the instruments I think if we were to look at remaining gaps, that's one we should take a look at seriously. We have a large family of mental health instruments, from inpatient psychiatry to community mental health and emergency screening for psychiatry. We've also been doing a fair bit of work in the forensic and prison systems, and we have a screener that we're testing right now in Wellington County. One of my PhD students is leading this. We have the OPP and the Guelph Police involved. We've trained police officers to use our brief mental health screener, and they're using it to identify who they take to the emerge for mental health emergencies versus just take them into holding that they probably don't have a serious mental health problem. So we're right in the testing phases for that. An instrument for adults with intellectual disabilities that we use in Ontario with the closure of the last 3 large institutions in the province. A palliative instrument that's being rolled out now in Ontario for community-based palliative care. physical rehab instrument, the interRAI CHA, the community health assessment that community support services are using them, starting to use across the province, as well as a deafblind supplement that goes with that. So the community and social services ministry is using that for deafblind individuals who need interpreter and intervener services. And then we have a new family of subjective quality of life instruments for long-term care settings, home and community care settings, and mental health settings.
John, for the acute care
Yes.
would you focus on specific populations? You had said it's more specific.
Yeah, that's what the different instruments apply to different age groups. So if you look at the acute care one is really the only one that you would use an age-based criterion to target. So it's not for everybody in acute care. We're targeting for people age 75 plus, or people that clinicians would say look like they're clinically complex enough to warrant it. Everything else can be used with an adult population 18 and over. Home care and long-term care tends to be dominated by elderly people, so most of the data that you see on those sectors are for the elderly. Whereas if you look at the mental health instrument, the average age of the mental health clients is around 45 years of age. And so the ED screener is also one that we target specifically at the elderly, not everybody that goes through emerge. So these are the 4 basic applications that we've designed all of our instruments to serve. So one of the questions for you guys to think about for Erie St. Clair is, are we making maximal use of every one of these 4 applications? Because if we aren't, that needs to become a priority focus for us, because the assessment, as Betty mentioned, takes about an hour to do. Once you've got it in place, that's not all it does. It doesn't just become a database for Hirdes and other researchers to use. It's a source of information every one of you in the room should be able to use for different purposes. So on the left-hand side are the clinical applications of the instruments. So those are applications around the person and the family. So the most important thing we designed all our instruments to do is to support development of a person-centered care plan. And so there's about 22 of these care planning protocols, new ones for the RAI-HC. There's an older generation that are still used in Ontario that we need to migrate to newer ones. But basically 22 different domain areas, things like mood, psychosocial functioning, cardiorespiratory function, risk of institutionalization, pain, incontinence, a full spectrum of medical, social, psychological, and environmental factors are addressed by it. We also have a series of outcome measures embedded in it. So when you put in place a care plan for the person, you can also track how well they're doing in terms of pain, depressive symptoms, medical complexity, physical disability, ability to do instrumental activities like taking care of their home, managing their medications, and so on. And I would say that, if I was sort of being a professor and assigning scores, we're probably at a B- level in terms of clinical practice in Ontario in terms of using those functions. We've got them there, but it's not as easy as it might be to sort of communicate with family members and home care clients to talk about that. And I think that's one of the areas that we could sort of look to in the next 5 years of how can we sort of improve clinician, client, and family interaction to make more use of that in day-to-day discussion, because I still see some tendency for folks to have filled out the form and that's the end of the conversation. On the right-hand side are the management applications. So I'm going to show you a bunch of analysis around resource allocation. And we can think about resource allocation in a variety of ways, from funding models that governments can use to staffing or managing case manager workload would be another example. Then we have a series of quality indicators that are embedded in it, so that when you do repeat assessments, you can look at the performance of the organization over time. It's all risk adjusted, so we can make sure that comparisons are fair. If you haven't noticed, the Health Quality Ontario report that it releases now on an annual basis includes interRAI's home care quality indicators. So your CCAC and your long-term care homes are being publicly reported on interRAI quality indicators. So from a management point of view, you want to know what these are all about so you can understand how your organization is performing. The key thing about interRAI instruments is you want all of these things working together at once, because there's a great tension that develops between them, which means that you don't want to necessarily skew information one way or another to try to sort of manipulate the system to your favor. So if you were to overstate things like level of ADL impairment, pressure ulcers, or things that cost more from a resource point of view, one would ask the question, well, why are you so high in all these functions on a persistent basis? Why is your quality of care apparently not matching peer organizations? Why is this region's home care program for long-term care homes not improving in ADL function as rapidly as the others? So the reporting of those indicators from a quality point of view counterbalances any bias that would occur of over-reporting things from a funding point of view. This has been an important issue in the long-term care home sector. It hasn't really happened in the home care side of things, but it's something you want to be aware of. But the key thing is that you want to really emphasize to your clinicians those two applications, because what that means is that they're going to get the assessment right because it's affecting decisions about Mrs. Smith. And who cares if the LHIN can use it for management purposes, or our finance people can use it for management purposes. I'm going to get this right because it matters to Mrs. Smith. So you really want to think about all these applications working together. You want the data to be as clean as possible so you can use this to inform decisions at multiple levels. It's also what makes the interRAI instruments very cost effective. So as Betty mentioned, the investment in staff time is about an hour assessment once every 6 months. If we look at routine reassessment patterns for home care clients, it's spending an hour with the client to decide what resource am I going to allocate over the course of the next 6 months based on this assessment. Out of that single assessment and then a reassessment that takes an hour again 6 months later, you get all these applications. So you don't have to go back and do some kind of accounting system for resource purposes. You don't have to go back to do another quality measure or track outcomes again over time. You get it as part of this complete package of the assessment and all these different applications. What you'll see later on in the day is that this diagram's got to change because there's now going to be a fifth new major application that you're going to feel compelled to start to make use of with the RAI HD and other interRAI instruments as well. We'll get toward that at the end of my talk.
So John, are your outcome measures mostly patient focused then, based on what you just said about Mrs. Smith?
Yeah, so they're clinical outcomes at the person level that you can aggregate at the population level to get information about quality, but at the person level, it's things like ADL functioning, depressive symptoms, pain, and so on. Yeah. Yep. So this gives a schematic of what's happening in the Canadian context. So the way to interpret this graph is that with a solid icon like that, it means that the government has either mandated the implementation of the instrument or recommended its implementation. If it's a hollow icon, it means that there's research projects, demonstration projects, or the like underway. So for the nursing home instrument, which is the RAI 2.0, we have 8 provinces and territories that are in different stages of implementing the nursing home RAI instrument. Ontario implemented for complex continuum care and long-term care more recently. And one of the things to know is that different provinces are at different stages of implementation. Ontario has tended to be the leading province in the country in terms of implementation of these different instruments. So we started in 1996. 2002, 2003 is when the home care instrument got mandated, and several other provinces followed. We're the first ones out of the gate in terms of the palliative care instrument. Nova Scotia and Yukon have announced that they're going to go that way, but they haven't started implementation yet like Ontario has. The CHA is being rolled out province-wide. This is the interRAI contact assessment, and that's for deaf-blind individuals, a variant of the CHA. That's the inpatient psychiatry instrument. So for nursing homes and home care, interRAI instruments have become the de facto national standard. On a national basis, CAI, the Canadian Institute for Health Information, operates reporting systems where those data go, and they do national statistical reporting on this information. They also do things called analyses in brief. Have any of you seen any of the CAI analyses in brief? Well, these are just focused little papers that they do on a specific topic. So they did one on depression in long-term care homes about 6 months ago. It got national coverage. All the major newspapers were covering it. They were on all the major television broadcasts, but even local papers were covering it as well. And that's important because it gets these issues into the minds of the general Canadian population. And they can only do that because of these large-scale implementations that are happening across the country. So for your LHIN, your complex continuum care beds, long-term care beds, home care beds, psychiatry beds, and palliative community slots and community support services and home care intake are all using mandated instruments. And so we could be having the same meeting here today, and instead of the CCAC folks, have folks from inpatient psychiatry or from long-term care. And that's great, but I think from the LHIN's perspective, what you really want to focus on is how do we get all these guys working together? How do we make sure that we exploit this opportunity of standards across the sector so things start to really function as a system? And it's been interesting to watch how things have evolved. Things have been implemented on a sector-by-sector basis, and we've sort of gone through sort of common pains of having to get staff to sort of go through the learning process of how to do these, fill out these forms, and how to sort of devote an hour of their time to doing an assessment and developing care plans. But we haven't yet really gone through the phase of saying, okay, long-term care and home care, let's figure out how you really work together so that we can put a longitudinal clinical record together where the person who's in a long-term care home can also have the previous RAI-HC assessment, so that staff in the long-term care home can look at it in terms of an historical clinical record that says what this person was like, to say, okay, this person seems to be confused now, but in the previous assessment was not confused. There's been some tendency to think, oh, that means the previous assessment was wrong. It doesn't mean it was wrong. It means something has changed clinically in the person. And for a change to happen in cognitive function, that suggests a potential emergency. Delirium is a very serious health condition that needs to be responded to very quickly. And having that longitudinal clinical record provides a real opportunity. We're nowhere really close to fully exploiting that longitudinal nature yet. All the holo icons sort of show things that are underway, different research projects and demonstration projects. So these are, the crosses are the emergency department screener study. We have something called the MOPED study, where we have hospital emergencies in 4 different provinces using that ED screener. It was part of that 9-country study. So we have about 1,500 people that have participated in that study. One of my PhD students is leading that effort. He's now been twice recognized as a sort of a rising star in terms of health services research by the Canadian Institute for Health Research. And he's interested in folks in the EMERGE and ALC patients. And one of the things that his study has shown, I can show you data from, but I know it's not in this talk, is that if you look at the CTAS score, how many of you are familiar with CTAS? Okay, and so who should not be in EMERGE based on their CTAS score? What's the cutoff for people that don't belong in EMERGE? 4? 4 or 5, right? 4 or 5. And that's sort of been the classic way of thinking about it. If you look at the CTAS score and then stratify it by emergency department screener, what we found is that 2/3 of the people with a CTAS of 4 or 5 have very complex needs. They're not coming to the EMERGE because they've got a medical emergency, but all hell's breaking loose in their family because of functional emergencies, cognitive issues. So they're not coming in there wasting tax dollars. They're trying to figure out how to access the system, and they're going there as a starting point. And those are people that with the ED screener, we can capture them, link them into the CCAC system, and reduce the probability of them coming back to the EMERGE. And if they go into the hospital, they're going to become your ALC patients. So you can start good quality geriatric interventions right away. So only about 1/3 of those 4s and 5s are ones that we would sort of say, they don't look like they have an acute medical emergency, and they don't look particularly complex from these longer standing issues, and that's more the size of the problem rather than all the 4s and 5s. So I'm going to show you some Canadian data now. So this is from a paper that I'm working on that's going to be the home care answer to the iron lungs paper. So the iron lungs paper, I was able to take data from all the round dots and do a comparison of long-term care homes across the country. Now I'm going to be working on the square boxes with home care data to start to compare home care across Canada. So far, we've only got data submitted to CAHI from 5 regions. So Alberta and Newfoundland and Saskatchewan haven't submitted their data yet because they're just in the earlier phases of their implementation. What this shows is 7 different care planning protocols. So I assume that one of the things the LHIN is interested in and the CCAC is interested in is population level need analysis. What kinds of needs do the citizens of Erie St. Clair have? Well, that's fundamentally what CAPs are all about. CAPs are these clinical assessment protocols. They tell you that somebody's at risk of a bad thing happening in a specific domain area or is currently experiencing the problem. So if we're to look at, well, what are the things that affect a lot of people in home care? A lot of people have issues with pain, depressed mood, falls, urinary incontinence, and ADL function. So around 50%, around half the people you serve in your CCAC have pain, and moderate to severe pain as an important issue. Over a third have issues related to depressed mood, and the rates vary across jurisdictions. So you see Ontario is around 38%, the Yukon gets around up to 50%. The Yukon population is a bit odd. It's almost a mixed mental health and elderly population. Depressive symptoms are a bit lower, but still important problems in Winnipeg and in Nova Scotia. Falls, about a third of Ontario home care clients have issues with falls. The red bars are people who are multiple fallers. So for the red portion of that bar, about 75% of those people are going to fall again in 90 days based on our evidence. So if you want to know about risk reduction and targeting interventions, there's a group. If you want to have a falls prevention strategy, you can put a very strong effort into about 15% of your home care population because they're almost certainly going to fall again and probably going to end up in your emerge if you don't do something about the fall risk. For the ADL cap, we trigger both on people who have got acute conditions that the intervention could improve. So if you want to think about how do you allocate scarce rehab resources, you can use that cap to target the people most likely to benefit from it. And we also, with the orange part, look at people where we want to prevent decline. Behavior is an interesting issue. It only affects around 10% of the population. Notice much higher rate in northern BC compared to others. But this one, even though it's fairly rare, is hugely important because behavior is a deal breaker between family members and the client. Family members can deal with a lot of things. They can deal with incontinence, they can deal with physical disability. Depression is hard on family members because depression is sort of an infectious disease in some sense. But behavior really ticks people off. It sort of breaks the social bond in the sense that, you know, I'm wearing myself out trying to take care of you, and then I get punched in the nose or I get yelled at. And so I was one of the consultants who worked on the Romano report, providing recommendations around home care, and was very worried about behavior. And this is one that got messed up completely in the First Minister's Accord. Because if you look at what happened in the First Minister's Accord, the focus went on generic mental health issues rather than this issue. When we wrote the recommendations for Romano, we said, focus on home care clients with behavior service, do sort of an ACT team equivalent for elderly people in home care, and somehow it got lost in the laundry, and that program wasn't part of the original package.
Ontario's trying to address it now, right, with the BSO?
Yeah, and it's critical. This is definitely one of the major risk factors to get folks institutional.
Would that be primarily dementia?
Any behavior arising from any sort. So with Alzheimer's disease, it's a major risk factor for it, but other mental illnesses can lead to that. Other medical conditions can lead to behavior disorders. So delirium can lead to behavior.
No, I realize that. I just wondered if that would be the, I mean, that's the one I hear a lot of, dementia patients living at home.
Yep.
And behavior or aggressive behavior.
Yep.
And what about the mood? I mean, that doesn't, what you've said doesn't, maybe we're not supposed to, I don't know, but I don't know that older people do have depression problems, but that's different than a 40-year-old depression. And therefore, the numbers would mean something totally different.
Well, I don't think it does.
No?
So depression we have sort of a view that depression is a normal part of aging. It's not. So lots of folks grow older and never have depressive symptoms. Depression is as much a clinical problem in older people as it is with younger people. There are many factors that increase with age that increase the probability of you having depressive symptoms. So spouse dying, a family member dying, you developing a severe chronic illness, or loss of functional ability, or loss of independence. So there's lots of things that sort of gang up on an older person that increase the risk of depressive symptoms. But that doesn't mean that depressive symptoms are a normal thing, and in fact they can harm the person's ability to cope with those challenges.
I didn't mean it was normal, I just meant that the interventions would be quite different. No?
Yeah, well, definitely the issues driving it may be different. We've got a paper that's just come out in the American Journal of Geriatric Psychiatry that we call Good News and Bad News. Depressive symptoms decline with advanced age, but under treatment increases. It came from ontarIRAI home care data and Ontario complex continuum care data. What we saw is as you move from people that are 65 years old to 95, the rates of depressive symptoms go down quite substantially. Whereas if you look at those who have depressive symptoms with age, as they get older, under treatment increases substantially. And so there's this sort of fear of treatment of depression in people with very advanced age. But the point about it going down is kind of mixed, because what we see is in home care, being 90 years old and being still at home, even if you're getting home care, life's pretty good. I'm still able to do a lot of things independently, and so depressive symptoms are lower there. 90-year-olds in an institutional setting are just as depressed as 65-year-olds in an institutional setting. So keeping people independent in the community is one of the major things that we can do to help with people's quality of life, and then dealing with all these things like disability and the other factors that lead to depressive symptoms are things we should be dealing with as well. But then there's a clinical component as well, that physician practice patterns seem to vary as you get into people that are in advanced age. Any other questions on this one? Okay. So this is a slide that shows you some of the things you can do with national data and cross-sector data. What we do here is we look at the average score in the cognitive performance scale. This goes from a 0 for cognitively intact all the way to a 6 for people that are very severely impaired. And this is our mean ADL long form scale, which is 0 for fully independent to it's about 28 for completely impaired in 7 different domain areas. The red diamonds are home care, and the black diamonds are nursing homes, and the labels are the provinces or territories that they're from. So a couple things you see quickly is that there's a clear distinction between home care across the country and facility-based care across the country. So, you know, the combination of ADL impairment and cognitive impairment is probably one of the things that is more likely to move you into an institutional setting. That makes some sense. But even within the sector, you'll see there are some interesting differences, that the Saskatchewan home care population actually looks much more impaired than the rest of the country. Ontario and Nova Scotia look fairly similar to each other. Manitoba tends to serve a lighter population. Yukon has a more cognitively impaired and less physically impaired population than others. So there's some subtle differences that we see in home care across the country. If I was to show you this with other indicators, you see there's bigger differences in the home care population than just looking at averages would suggest. What it means is that you can't assume that what you read about home care in one jurisdiction applies to your own jurisdiction. You have to control for population differences in terms of who's being served. You know, I could have had 500 slides today. One of the 500 I didn't put up was a comparison of home care clients in Canada with those from around the world. And what it shows is that our home care clients tend to be sort of in the middle of the pack. The southern Europeans, so France and Italy, serve a much heavier population than Ontario does. And the Northern Europeans, the Scandinavians, serve a much lighter population than Ontario does. So if you're to look at home care clients in Iceland, Finland, Norway, Sweden, and Denmark, they look lighter than the Manitoba population. So don't be picking up a newspaper and seeing something miraculous happens in Denmark and think we're doing a bad job here, because we're talking about a different population in those settings. And any comparison that gets done cross-nationally has to control for those personal characteristics, and also any national comparison that we do has to control for those differences. So when the HQO does a quality indicator on home care in Erie St. Clair compared to everybody else, it has to be risk adjusted, and we develop those methods for it.
Just a question around British Columbia and Alberta, how they are with the red dots.
I have no idea about Alberta yet, because we don't have Alberta data for either sector yet. The BC data for northern BC is, we just got the data before this comes out of that Iron Lungs paper. The BC data are a little bit more impaired than Nova Scotia, a little bit higher end. Yeah.
Patient load or I can understand, but would there be other variables like public education in terms of the options between institutional or policy questions that drive people to an institution as opposed to home care?
Yeah, the thing is when you start to look at some of these differences, you can link it back to some policy differences. So Manitoba has always been a province that's prided itself on providing broader access to home care services. When you do that, you reach into a less impaired population. And the question is, with that less impaired population, can you therefore reduce the likelihood of a future institutionalization, or should you wait until they're more impaired before you provide services? The question is when you start to intervene with them. I think if we were to look at what's happening in Ontario with things like Home First, what's going to happen is that this line, this dot in Ontario is going to start to move up in this direction for our home care. Because what's happening with Home First is that people who would have been here are now being moved into the home care side of things. And in order to deal with that increased volume and service demands, the people that would be at the lighter end are getting off the service, so the mean's going to start to drift up. So as you think about resource planning for the CCAC, you need to think about not just raw volumes of who you're serving, but the complexity of the people that you're serving, because their costs are going to go up as you start to take on these folks. Because the average cost for these guys is about $130 a week, if I was to look at Ontario cost data. The average cost for these guys is $150 a day. And moving those folks back into home care, a lot of the costs will be absorbed by putting a lot more demands on family, but not all of those costs. So when we need to do something like Home First because it's the right thing clinically to do, to keep people in the community as long as possible. But it will certainly mean increased resource intensity for the home care sector. Any other?
Just a quick question on, was Ontario split between north and south, like Alberta, like BC? No, or is it just?
Oh, we can do it by all 14
So
CCAs.
why would BC be separate? Northern BC?
There's five health regions, and northern BC is the first one to submit their data. All the others are dragging their
I was
butts.
thinking that, okay, thanks.
Yeah.
I guess I just want to go, you don't mind us asking?
No.
So to drive, if we want to drive more people, forget Home First,
Yeah.
that's a good program that moves it, but there's other issues like public education and changing the attitudes of kids of older people so that we never get to the institutional point. And that's a job of maybe CCAC, but certainly the ministry and LHINs. We know whether other jurisdictions, especially Europe, have done that type of thing, and that drives different rates of use as well. Because we still, logically, I think in this province that you get to a certain age and you go into an institution.
Yeah. What we see in the Nordic countries is that they tend to serve both a lighter nursing home population and a lighter home care population. So they provide more services to a broader spectrum of people. Whereas in Canada, we've been moving more to trying to get those sectors to deal with the people with the higher end need. There is a challenge about what happens with the people with the lower end needs. To some extent, our thinking is, well, they'll be fine. They've got low end needs. But low needs does not mean no needs. And for me, the issue is not sort of a threshold. If you're this bad, you get services, but if you're less than that, you get no services. What we want is more of a calibration of different types of services for different populations. So it's working with people that are starting to show signs of trouble to keep them independently in the community with interventions that don't necessarily mean 5 hours of PSW time a week, but might mean some other interventions. But that may include education, but it may also include some more clinically oriented interventions, for example, interventions to reduce risk of future falls. So if you've got somebody who's a first-time faller, that may be enough to set off a warning flag for you that something has to happen in terms of an intervention to stop that person from going down a further cascade. There's some discussion in the quality literature among experts that the falls that we care about are the ones that result in emergency department visits as injurious falls. I don't buy that, because the difference between a fall that got you in the emerge and one that didn't could be a matter of where you fell. Did you happen to fall and hit the corner of the table with your head, or did you just miss and you've got a sore shoulder, but that's it? So to me, any fall is a warning sign, not just one that got you in the emerge. So, a calibrated intervention rather than threshold, I think, is important, and thinking about intervening early to things that may cause much bigger problems down the road are two of the things I would suggest.
So John, should the focus be on quality then? Because if we're moving down, we have improvements in cognitive performance.
Yeah.
Really, it's a quality of life issue that we're leaving at performing, so
Yeah.
that one of our guiding principles. So to
Well,
speak.
quality has to be something you look at no matter who you're talking about. It's got to be a risk-adjusted quality indicator. So you look at your light care clients compared to other light care clients and heavy care clients compared to others. So I think objective measures of quality are things that you want to use no matter what on a routine basis. And for the CCAC board or the LHIN board, taking a look at the Erie St. Clair performance on long-term care and home care QIs should become a routine part of your business to see how you're doing compared to other jurisdictions.
Yeah, one of the issues is we don't have ready access to the home care data, and we're working with CAI to get that, but we do look at the long-term care data quite frequently in the
Yeah.
CCC.
Yeah. So that's back to this thing that we're sort of moving beyond the stage of gathering more data. Now we're in the phase we're going to figure out how to use the data, and there's some goofy technical challenges like why don't you have access to your data? That just shouldn't be the case. And then there's also some human resource challenges in terms of do you have the people with the expertise to analyze the data to give your boards evidence that they can be comfortable with, and there's a real dearth of that, and those are the kind of people we're training at the University of Waterloo. All of our masters and PhD students get a lot of education in quantitative data analysis. We've got new masters in health informatics and other masters in evaluation coming forward because we see an enormous market for graduates of this type that can work with these complex data sets.
And to the interaction with the CHA as well, right? And that helps us create that calibrated system so that we're, and I know I'm speaking to the choir, but engaging our CSS, our community support agencies to help with that calibration.
Yep. Yep. All right. So that was the introduction, 40 minutes in. So now we'll go to one of the bigger, more complicated studies. So the Canadian Staff Time and Resource Intensity Verification Project was a 2.5-year study. It was a 3-year study. It was $2.5 million funded by the ministry and CAI to look at the case mix applications of the interRAI nursing home and home care instruments. So if you're not familiar with case mix systems, what they do is they give you a methodology for describing the relative resource use of one group of individuals compared to some reference group. So who's more expensive or less expensive to provide services to among your client caseload. And you can use these for a whole bunch of different purposes. The ministry can and should use it for funding purposes to have resources allocated based on the clinical needs of the populations that are being served. But you can also use it from a staffing point of view. So if you're looking at case managers, you can look at the case mix system and say, well, she's got a much heavier caseload than he does, and maybe we need to readjust that in terms of the complexity of the caseload on individual case managers. For quality indicators, it's used all the time for risk adjustment, for sure. You can use it from a planning point of view. So you can think of it not just in terms of I want to shift the ADL and CPS scores, but I want to, if I use the case mix measure, I'm taking into account about 100 variables. You can sort of think about, well, how do I target certain populations using that? So the Health Services Restructuring Commission in the 1990s used the resource utilization groups, the case mix system for nursing homes, to identify who CCC should be serving and who long-term care should be serving. It's the best Canadian example of use of that for planning purposes. And when you look at what happened, it clearly differentiated those populations down the road. And you can use it for program evaluation. In fact, any evaluation you would want to do with Erie St. Clair compared to any other LHIN, you have to adjust for case mix, otherwise you're not making a fair comparison.
So in terms of, Brad's been talking about this, about using the RUG data, that's not something that our CCACs individually can do, right? Or it's an additional cost for their vendor to run the data?
Well, it's back to the data are there, and why can't we get this information? Because I mean, this is now 10-year-old research, the original RUG research. So that's an important barrier to you. If your vendor is charging more for it, deal with the vendor, say it's got to be part of the package. If you're not getting it as part of the routine from OACCAC, then that should be something you should be asking for. It should be in your standard board reports. So the only reasons for not having this are IT and information system issues. There's not a scientific reason for not having this or using it. One of the important distinctions to make, though, is that there's a difference between a case mix system and a payment system. So what a payment system is ultimately your funding formula of how you reimburse organizations. It can include case mix, but it often includes many other considerations. So the funding formula is probably case mix plus some other factors, ruralness, northernness, teachingness, all those other modifiers that come into play. And so it also tends to be more of a political piece of information, whereas case mix is an empirical piece of information. So case mix tells you about how heavy your clients are. The payment system will tell you ultimately how you're reimbursed. And so the HBAM system that there's lots of discussion on in Ontario is really a payment system that might include case mix from the RAI-HC.
Does.
Right.
I'm on that committee.
Okay. So if we think about how we design case mix systems for home care, home care is interesting because it's different from other settings and has some commonalities. So the first thing is that you probably want a case mix system that relates to the nursing home case mix system in some ways, because there are important common populations between the two sectors. So there are people that stay in one sector or the other for a long time that look just like each other, where they have the same set of needs, but one just happens to be in home care, the other just happens to be nursing home, often because of the availability of a spouse or another informal caregiver. And then there are people who move from one setting to the other. Your clients that are moving from home care into nursing homes look just like nursing home clients while they're in home care. But there's other folks that could be moving from the nursing home sector back into home care that look like home care clients as well. So probably what you want is a case mix system that has some consistency between those two different settings. However, there are some clinical factors that are going to affect case mix in each setting. So if we were to look at ADL impairment and cognitive impairment, I've just shown you a slide that shows there's lower impairment scores in the home care population. What that means is that IADL isn't as powerful an explanatory variable for predicting resource use in home care as it is in nursing home settings. But ADLs are not.
Yeah.
But IADLs turn out to be important. Your ability to manage medications, do housework, make your own meals is a predictor of resource use in home care, whereas in nursing homes, people don't make their own meals for the most part. So some of the clinical variables in that common case mix system are going to need to be dealt with in a slightly different way. But the big challenge in home care is most of the care comes from family. So 3/4, based on our data, where we're looking at hours of care, comes from informal sources rather than formal sources. And you can't provide home care without family members. Those folks end up in long-term care. So you need to figure out a way to add some economic value to the care that's provided by family members if you're going to try to measure total resource use. So this is the RUG home care system, and it builds off of Brian Freese's earlier work for the nursing home instrument. Then it was tested. It was derived in Michigan, later validated by Jeff Pawson in a study that included folks from this region. The RUG system in home care looks just like the nursing home in terms of its backbone. It's 7 hierarchical levels, from special rehab to extensive services, special care, clinical complex, impaired cognition, behavior, and reduced physical function. Then it differentiates on ADL for the most part. And there's other factors that come into play to differentiate it further. When we talked about the structure, so there's 23 groups involved in it. And you'll see that in addition to the ADL splits that you see on the nursing home side, IADL is a further split in the home care side of things. We then did a research project. Jeff Haas did his PhD on it. That was a project funded by 8 of the CCACs prior to the merger into 14. So folks in this area participated in that as well. When we compared the CMIs that came from the original Michigan study to what we got from those 8 CCACs, a very strong relationship. So basically, we validated those results to the original derivation study. But then people had questions of, well, is Erie St. Clair all the way up to the Waterloo area? Are those all just weird people? The answer is yes, but maybe the results may still be generalizable. And the other question that came up was, well, the cost study was done in 2004. Home care's changed so much. Can we be sure that the practice patterns haven't affected the generalizability of results? So with the CanStride project, we did a further validation study. This time, we took 443,000 RAI home care assessments and linked those data to cost data from the CRIS system. So every LHIN, every CCAC was represented. Everybody that there was data for, so it's virtually census level data between 2005 2008 were in the study, except for people awaiting long-term care placement or in hospital. So the RAI-HC also provided us estimates of informal care time that we could use to come up with a shadow costed informal care time. We used the CRIS system to get 13-week costs of billings to CCACs. We could wage weight those billings based on the type of professional providing those services. And we could track what happened to people over time. So if we look at 4 different sectors, or 3 different sectors, 4 different time periods, this is home care, the CCAC sector, nursing homes in Ontario, complex continuum care in 1997 prior to Health Services Restructuring Commission recommendations, and then afterward. These are the 7 hierarchical RUG levels that I've just shown you. What you see is that policy directive of changing the role of CCC clearly shows up in the data. They're serving a very different population. There's very few of these folks left. The Restructuring Commission says they need to go to long-term care, and that's generally where they ended up. Whereas long-term care provides very few rehab services compared to CCC. So there's a real transition in that sector over time. Complex continuum care is different from long-term care. There are some common populations, but the ratios are different. But interestingly, home care and long-term care, those crude structures are fairly similar. That there's lots of folks in home care settings that look sort of comparable to folks in long-term care settings. This shows the results from the original 8 CCAC study in green and the validation study in blue, the CanStride study, looking at the distribution of all 23 RUG-HC categories. So green is Southern Ontario, blue is all of Ontario, and what you can see is aside from minor differences, which may be partly temporal effects, there's no real major difference in the distributions in the RUG scores over time, except for a reduction of home care clients in the rehab services that might be either a regional or an historical effect. This looks at the CMIs, the weights that you would attach to it, and that tells you how more resource intensive is this person compared to others. And if you look at 22 of these bars, there's virtually no meaningful difference between the weights from the original 8 CCAC study and the province-wide study. The only one that changes a lot is SE2, which actually the CMI went up. That's because it's a small group, an extremely expensive group. We only had about 15 cases in the 8 CCAC study, and now we ended up with 50 cases or something like that. But for the most part, the CMIs are very stable in the validation study. If we look in terms of explained variance, explaining both formal and informal costs, we have about the same explanatory power at 36%, which is better than what you see in medical DRGs. And if we look at temporal effects, no real temporal effect in explained variance. And if we look at effects across LHINs, you guys are right in the middle of the pack. Pretty much the same explained variance in terms of the case mix system. So what that means is that, you know, there's these systems are stable, whether you're looking at the CMIs, regional effects, historical effects. It's behaving pretty much the same way over time and across CCAC. So this is a tool that there's no reason for us to not start to use for those 4 different applications. Whether you know, how it gets used in HBAM, we shouldn't limit ourselves to that. You could use it as a management application on a day-to-day basis, and it should be something that your IT system gets you.
This is a quick question. Sorry.
Yeah.
Does this also say to us, we've heard anecdotally that 30% of the people who are in long-term care homes in the end don't belong there after 3 months. Is it also telling us that maybe we have too light of a patient in long-term care when we kind of see home care and long-term care almost right next to each other?
Yeah, well, so it's these folks that are sort of interested in the light blue that are over half in both populations. Now, if I was to look at the home care population, the light blue is this PA1 to there's a PE group in the run for nursing homes. The long-term care folks do tend to cluster a little bit more in these where there's fewer folks in home care. You see about half the long-stay home care clients are in the bottom 2 run categories. If you were to look at a model of switching people out of long-term care back into home care, that's where I'd start. I mean, half your clients are in this category, so you know you can handle them. And so if we can get those folks out of long-term care, let's say they're 10%, and we can get half those folks out, that's, you know, reducing that load by half in long-term care, but getting them back into the community, that can make a big difference. The challenges are probably around availability of informal support. So that's where things like supportive housing or alternative housing models may come into play, or looking at some kind of a community-based assisted living program that means that they're going to need some more intense services there for them as well. But the thing to know now, thinking from the LHIN's perspective, is let's say that we're talking about the nursing home rug distribution, which is going to be shifted a little bit more to the left. When you take these folks out of long-term care home system, you're taking out the residents that they're basically making money on. They have lower cost needs, and they may be using that to counterbalance the folks that they're losing money on. And so the right answer is to get a case mix system in that reflects the needs of the persons, rather than using this sort of counterbalancing technique. Because for long-term care homes, their case mix will go up, and we need to be sure that the payment system uses the RUG case mix system in a way that reimburses appropriately for those higher needs. Yeah.
I mean, that's, as a non-professional, that's one way of looking at it. The other way of looking at it is they can afford to take a heavier load because we don't need to build more long-term care facilities. And we can take those resources and invest them in the existing long-term care facilities and have a heavier workload. But the barriers, to me, are much more, the government has to change all sorts of rules of how they're paid, and we have to change the culture. I mean, kids, as soon as older people get to a certain age and they're in the system, the kids rent out the apartment or sell the house and sell the furniture, and therefore you're there for life. So I don't know, this one to me isn't just the data proves the point, but it's the policy questions are much more
Well, there's a couple things to sort of think about here. One of them is that I would not want to get into the trap that that we sort of comfort ourselves to think that there is not enough money in the long-term care system. I think the money that's in there now is working when you've got this sort of two sides of the teeter-totter, where there are some lower cost folks there. When we did staff time measurement studies in nursing homes and complex continuum care, the main conclusion I would come to looking at those data is that the complex folks in long-term care are under-resourced. And so one of the things that could be dangerous is if you take out these light care folks and don't think about the reimbursement to long-term care homes for those complex people, your ELC days are going to go up because they're going to punt them out of the long-term care home into the hospital faster. In that Iron Lungs paper, we're showing that Ontario has about the highest rate of discharge to hospital from long-term care across the country. And that's because the safety valve some of these homes use is to get these very complex folks into the hospital system. So I'm not convinced at all that nursing homes are ready enough and funded well enough yet for the complex folks that they're going to be left with. So I'll come to you in a moment. So the other part is the issue about institutionalization. A huge risk factor for institutionalization after you adjust for clinical needs is, do you have a spouse or not? And there's a tremendous difference between clients who live at home with a spouse compared to clients with the same level of need that are getting it from kids who don't live at home. And so that the spouse can do so much more than a child, even living 10 minutes away, can. And so the threshold for institutionalization for children living away from their family members is lower in terms of need because they just can't ramp up the care because of, they're not there 24 hours. And so women are the ones who are differentially affected by that, right? Because many, men have tended to marry a younger woman who's going to be healthy enough to keep him in the community. He dies, she gets institutionalized because he's not around. So this whole issue about the availability of the spouse is a very important dynamic there that affects institutionalization. So I don't think it's necessary. I wouldn't describe it as kids just willfully putting the relative into long-term care. But I very much buy your point about let's not rush into things once folks are in long-term care. That the idea of, okay, this is now a terminal destination, the Iron Lungs model, that you're in the long-term care, you're going to be there for good, so let's sell the house, sell everything. That does happen, and it prevents us getting folks back into the community from long-term care. In the U.S., there's a huge movement afoot now to find folks in nursing homes that could go back to the community, and we have to overcome that tendency of selling the resources for folks who are...
And the co-pays for government. I mean, the way it's funded has to change too.
Yep.
So I think my point is it builds on the last two items, and that is using the convalescent care model more in an enhanced fashion. One, in terms of providing extra funding to the long-term care homes, so it's whatever, $61 extra a day. The other thing is it gets rid of that copay piece, because that's not an issue. Thirdly, if we use it as a throughput model, the way we've tried to build on it here in our LHIN, it allows for people to, the ones that don't have a spouse there, relying on their children, the children feel like they've just maxed out, get them this enhanced care, and then they can likely return back sort of in a safe environment. And still, we're compensating our long-term care homes, hopefully in a differential fashion, so that they continue to take these complex
I think that the convalescent care, there's some real opportunities there to make a difference in a way that helps the system, and it keeps it as a temporary transition in the kids' minds, so they're not going to rush off to do these things. And one of the tricks there will be to get rehab resources allocated in a way that makes sense. We do have a mess in the province right now in terms of how rehab is being provided in long-term care homes. There are some homes that are doing a great job providing very good rehabilitative care and getting real outcomes, and there's some unseen stuff happening as well. And unfortunately, both are happening And so I think we need to take a very critical look at how rehab resources are being allocated in long-term care so we can reward the good models. There's ways to spot the homes that are using rehab in a way that's not appropriate, and flip side, find ones who are doing a good job. Part of it comes back to the quality indicators. So if I was to sort of zoom back for a moment to this slide, the way the RUG system works is that you get more money for people that are getting rehab services. It's sort of almost a fee-for-service model built into the top end of the RUG distribution. What we can show in Ontario is that there are some homes that score high in the RUG system because they claim to be providing a lot of rehab, but they're doing terrible on the ADL quality indicators. So you, in a very targeted way, can say, okay, how come you're at the 90th percentile for rehab and you have worse ADL outcomes than people providing no rehab? That's an easy way to scare the pants off of anybody who's doing this for bad reasons. And it's also a way to reinforce the ones who are doing a good job by getting good ADL outcomes. Yes?
Your point about the daughter-in-law and the son that want to sell the house or think that they have to put me in there to get my name. I sometimes think that we're a million miles away from the public, or they're a million miles away from us, because this comes up time and time again of where we're going and how we see the health system, but it's totally different planet, I think, from how a lot of those people out there. Why can't we get a little closer on this?
Well, I think it's where LHINs and CCACs and researchers need to do a lot of public education and change ways of people thinking about how the healthcare system works. You know, and it's why I was so pleased to do that paper on iron lungs and gerontology, because the real message about it is change the role of long-term care homes so that they don't just become a terminal destination, that they can actually get people to improve and bring them back to the community. There are jurisdictions that are doing that successfully. The flip side is, within the last 2 weeks, I had somebody who was a leading physician in the long-term care sector publicly pronounced that you need to think about nursing homes as one giant palliative care program where decline is inevitable and everybody will die. That's 1985 thinking, and that we can't have. You know, that there are lots of homes that have better outcomes on things like ADL, and we need to find those homes and use them as models for what long-term care should be like. And this idea of it not being a terminal endpoint should become an expectation. That we can start to look in terms of a performance measure for nursing homes. How many folks did they discharge home compared to folks that they discharged to hospitals or dead? And again, it's got to be risk adjusted. Betty and.
Is there a possibility that you could also look at convalescent care in the community? I mean, we're serving the same kind of patients anywhere. Properly resource home care with more rehab resources.
Yeah.
And we could do it in the home because we're serving those people anyways. We're bringing them home,
Yeah.
especially those with a spouse, and we might need to get more respite care.
Yeah.
But it seems people always look to funding the institutions for
Right.
enhanced care rather than funding
Yeah.
the community for enhanced care.
It means that we've got to be able to ramp up services in response to needs. So when we looked at patterns of rehab allocation in CCACs in Ontario, what we see is that there's sort of the standard bolus that everybody gets. What are they? Oh yeah, there we go. That you get 4 visits. Not more, not less. You get 4 visits and you're done. That's not going to work for somebody who needs convalescent care. That's sort of a major event. It may be something that's more like a 4-week or an 8-week episode of more intensive intervention. Maybe we need to look at models of transporting people to clinics and so on. But you can't just go with one standard package and assume that it's always going to work. So community-based rehab, yes, of course it makes some sense. You need to think about the availability of a spouse or whether the person has moved in with another primary caregiver to provide the support, because otherwise the economics may not work out. So looking at a short-term facility-based option may be cost-effective for some populations and others. But I think you want an approach, a coordinated system approach that makes sense.
Have you identified any jurisdictions that have actually made the change with their long-term care homes where it's more convalescent? So patients will look at it through the lens of, I don't have to pick my top 1 or 2 or 3 locations that I want to go to. I'm just going to one of those locations for 90 days and I'm coming out. It changes the picture. So have you seen any jurisdictions that have started to make that move?
Mainly in the U.S. So in the U.S., where you see more skilled nursing facilities, and you'll see more that are sort of shorter-term places with more intensive rehab programs. But also in the U.S., there's a real surge now of states looking at finding folks in long-term care that could be moving out. And they're starting with the easy ones. And in many cases, the easier ones are younger people with physical disabilities that can live in more independent living settings. But you don't have to stop there. Brian Trees within the interRAI group is sort of one of the people that's leading this out. The next sequence of slides I want to show you are from a research project that's underway right now. The previous one is one that we sent in the final report to the ministry, and it's in the process of being used or not used, however things happen in the ministry side of things. This one is now about a project that's underway, funded by Public Health Agency of Canada. It's a 2.5-year, $1.5 million study. Looking at the issue of persons with neurological conditions and what their needs are, the resource needs, and so on. If you think about that schematic that I showed of Canada, that shows the nursing home and the home care instrument being used in 8 provinces and territories, mental health now being used in Ontario, Newfoundland, and Manitoba are the next likely to adopt that. One of the things that's true is that if you are a home care client with MS in Ontario or those 7 other jurisdictions, or a nursing home resident with Alzheimer's Society or complex continuum care patient with ALS, you're being assessed with an interRAI instrument. Care plans are being developed with interRAI care planning protocols. The quality of your care is being judged based on interRAI quality indicators. Resource allocation is happening based on interRAI-based quality indicators. And the question comes up as well, do we know that it applies to you as somebody who's got a neurological condition, as well as it might, some generic other in either of those, in any of those care settings. So we've got a team of about 14 researchers, a mixture of health services researchers like myself and neurologists involved in this. It's sort of exciting for the first time to have collaborated with a large group of medical specialists who are generally kind of shocked at the volume of data that we've got available for this population that they didn't know about before. So these are the 8 things that we have to achieve in this project. One is that we're doing just a straight estimate of the prevalence of neurological conditions across the continuum. We're developing clinical profiles of 10 priority neurological conditions. We're looking at the applicability of the CAPS, the quality indicators. We're looking at service utilization of people with neurological conditions, looking at cost of care, both formal and informal costs. We're looking at performance of the health system for those neurological conditions, and doing additional work around caregiver issues. Now, because we have that implementation across the country, we've been starting to get data in to the University of Waterloo. So if we look at, you're not necessarily going to be able to see all the numbers, multiple sclerosis. The biggest, baddest database historically for MS has been the NARCOMS database, which is mainly a North American collaborative database for multiple sclerosis. It's got about 35,000 registrants, all the voluntary registrants, most of them from the United States, and they tend to be healthier people with MS. It has a total of 500 Canadians in it, the last time I heard an estimate from it. If we were to look at data that have been submitted so far, so this does not include BC data, Saskatchewan data, Newfoundland data, so all of those early implementers, we already have data on 11,000 people with MS. For Parkinson's disease, 35,000 people with Parkinson's disease, 180,000 people with Alzheimer's disease, 980 people with Huntington's disease. It's almost impossible to publish a paper in Huntington's because it's such a rare condition. When I was developing the proposal for this, I took a look at a Lancet review on Lou Gehrig's disease, ALS. And there were 5 papers published on end-of-life care for sort of chronic continuum care issues for people with ALS. Of those 5 papers, one was in the Turkish Journal of Neurology, It might be a good journal. It's probably not the #1 neurology journal in the world. Most of those studies had about 100 people in them. We have 980 people not 980, 1,634 people with ALS in the data set. So in terms of understanding rare populations, these large databases that build up from normal clinical practice in the Canadian context give us the ability to understand the needs of people that it was impossible to get data for them before. So I'm going to show you some examples of different things that we've found. Boy, it's funny, the projector really sort of gets rid of any contrast, so I'll have to try to do some interpretation for you in some of the shaded areas. This first thing looks at pain, in this case home care clients, across the different neurological conditions, from Alzheimer's through to muscular dystrophy. 0 are people who got no pain to speak of in the last 3 days. What you see is there's huge variability across neurological conditions. As few as only 35% have no pain for traumatic brain injury, and for Huntington's disease, 70% have no pain. If you look at the 3s, these are people who have daily pain that they describe as horrible or excruciating. And that ranges from a low of about 5% for the Huntington's folks to 20% for people with spinal cord injury. So across the neurological conditions, huge differences in terms of pain severity. And so we probably shouldn't think of neurological conditions as one homogeneous group of individuals. If we look at people with Alzheimer's disease, because we have these instruments in different care settings, we can understand the needs of people with the same diagnosis across different sectors of the healthcare system. So this looks at age structure for Alzheimer's disease, and what we see is that people under 65 with Alzheimer's or related dementia, that's about 10% of the population in inpatient psychiatry, compared to less than 5% in the nursing home side of things. If you look at age 85 and over, that's about 20% of the people with dementia in psychiatry, about 25% of people in home care, and about 50% of people in long-term care settings. So with the same diagnostic general group, very different patterns in terms of the age structures across those different clinical settings, even though we would have labeled them with the same diagnosis. Then we can look at cognitive performance. So the cognitive performance scale is this measure of cognitive impairment. 0 is intact, 6 is very severely impaired end-stage disease. If we look again, these are people with Alzheimer's or related dementia. In mental health, nursing home, and complex continuing care, very few people score at that lowest level of cognitive impairment. We do see about 15% of home care clients with that diagnosis are still at the very low levels of cognitive impairment. They're probably, about to sort of move up because it's very unusual for folks to be at that level of cognitive impairment. But if you look at the CPS 4 or more, these are folks where you see a lot of behavior issues coming into play and a lot of difficulty functioning independently in the community. In home care, it's about 20% of the dementia population. Long-term care, it's about 35%, but in inpatient psychiatry, it's about 55%. Yeah,
What year is this data?
These would be around 2007, 2008.
I'm just blown away by the complex continuum care, just the amount of people that are there with severe pain.
Yeah.
I would suggest that patterns change dramatically, because when I'm looking at 45% of the folks in CCC in the province are considered long-term care.
Yeah, 3LC.
So this may be what it should look like. What we've got now is a very different population perhaps because of the pressures on long-term care.
My guess is you'll still see this. In complex continuing care, you'll still see lots of folks with lots of severe cognitive impairment and other things going on top of that.
But they're classed as long-term care weights.
They may well be,
Yeah,
But there'll also be CCC, pure CCC folks will have significant cognitive impairment as well.
Sure.
My main point here is that if you look at sort of an apparently homogeneous diagnostic group, they're very clinically diverse in terms of clinical characteristics across the different care settings. This now looks at people with MS and does the same thing around age distribution. So in inpatient psychiatry, 90% of the MS patients are under 65. In nursing homes, about 55% of MS patients are under 65, but almost half are over 65. So the age structure for MS across different settings differs. And if we look at cognitive performance for people with MS, many more folks with MS are cognitively intact in inpatient psychiatry and home care, but many fewer are cognitively intact in complex continuum care and long-term care. So even something as pure as you might think as MS, there's considerable diversity across different service settings. So that's sort of, some of the work we're doing around clinical profile that basically makes the point that just because somebody has a given diagnosis doesn't mean that you can understand what their needs are. You need something like an interRAI assessment to understand the true clinical characteristics underlying it. That function is much more important in explaining what the person's needs are than the diagnosis alone. Yeah, Betty.
I love the slide on the, where people are being, where they are being treated. That, if you go back to that.
This one?
No, the one with all the, just to indicate the number of people that are being cared for at home when you look in relation. Multiple sclerosis, over half of them are at home. In the home care system.
Yeah, and
half of people with Parkinson's.
well, I mean, if you just, there's about 170,000 people a year assessed for the RAI-HC. There's about 67,000 long-term care residents per year, I think. Yeah, I mean, home care is, a huge provider of services, at least a 2-to-1 ratio.
It's just a good, because some people don't understand the scope of it.
Yeah.
You talk about the person with, that are in a different setting, so I just think it's just an interesting slide. The other thing that I comment on is I'm just absolutely perplexed that the Ministry of Health never required community mental health to use interRAI. I cannot understand that. I just cannot understand it. It'll take them forever to catch up.
Yeah, it was a silly decision. It became a political decision rather than a decision about integration of the system. We do have we have one hospital in Ontario that is using the interRAI community mental health for their outpatient services, and there is a CCAC that's talking about using it for their urban health program.
But the rehab, inpatient rehab is
No, the decision there was to stick with the FIM because that was being used in the U.S. And in the U.S., initially there was a contract to use the interRAI post-acute care. The rehab industry didn't want to use it because they didn't want a per diem case mix system. They wanted an episode-based case mix system. Because with a length of stay-based case mix system, you can always push length of stay down a little bit more, whereas per diem systems are harder to modify. And now what Ontario rehab providers are starting to realize is that when they look at their lengths of stay compared to the U.S. counterparts, we're double. And so there's tremendous pressure to sort of do the same kind of thing, and it creates all kinds of bad incentives, and I think they'll rue the day.
And is there a private rehab tool?
Yes, post-acute care. Israel is using that, and Iceland are two that are using that.
Is the rehab piece in the States also a reflection of the increase of resources over the weekend and all that work that they're doing in the States? So they're matching the resource accordingly?
That wasn't part of the decision at the time to go with the FIM versus the interRAI PAC.
No, but now.
Yeah.
You're saying the double length of stay is probably reflected.
Yeah.
I mean, the thing about length of stay-based case mix systems is that from an organization point of view, you can always find a way to discharge the person sooner, whether it would benefit them or not. And in psychiatry, it's why you'll have seen many mental health professionals rage against the DRG system. That length of stay-based system is terrible in psychiatry, and it's why they generally liked what we did around the skip case mix system for psychiatry, which is more of a per diem-based system. All right, now I want to take you back to the neurology folks. This is something called the MAPLE algorithm, method for assigning priority levels. It's an algorithm that we use to identify the person's needs for community or facility-based services. So this is sort of like a thermometer. It tells you how much trouble the person is in, what the person's level of risk is for being admitted to long-term care, and who should be higher on your priority list for getting them more community services or faster access to facility-based services if needed. It takes into account a bunch of different clinical variables. So physical disability, behavior disturbance. Remember, we talked about behavior being a major risk factor for nursing home placement. Cognitive impairment, falls, problems managing meals, wandering, the nursing home risk care planning protocol, changes in decision making, pressure ulcers, and problems with meal preparation. So it basically identifies a number of folks as very high risk for caregiver distress or nursing home placement. So being physically disabled and a behavior disturbance is a very high risk group. If you don't have behavior disturbance, but you're physically disabled and have cognitive impairment and falls, that's another group that caregivers really struggle with. The other one is no physical impairment, but cognitive impairment combined with behavior or wandering are major risk factors that mean caregivers are going to struggle and you're more likely to end up in long-term care. So we designed this as an indicator that people could use for prioritizing who should go into long-term care and who should be a higher priority for more community-based services. We developed it for the general population. The question is, does that work with people with neurological conditions? So this looks at people with brain injury or head injury, and everybody else with a neurological condition, and people who did not have a neurological condition and did not have stroke in the home care population in Ontario in 2010 data. So what you see in the brain injury population, only about 10% are in that bottom end of that algorithm. So about 10% have no ADL impairment, very little cognitive impairment, no behavior issues, no changes in decision making, no problems with environment or med management, no pressure ulcers, and they screen as being self-reliant. That's only about 10% of the brain injury folks, compared to about 30% of the general non-neurological, non-stroke population. If we look at the other end, those very high groups of, the combinations of physical disability, behavior, cognition, and falls, for the brain injury folks, about 20% of them are there. The other neurological conditions, about 30% compared to about 5% in the general non-neurological, non-stroke population. So there are differences in where these people score on this sort of thermometer equivalent for need. The question is this difference real? Does it translate into something meaningful in terms of the person's experience or the caregiver's experience? So we can look at the relationship between the MAPLE level and rates of caregiver distress, which we used to derive it originally, and we see that there's basically the same relationship across all three groups. The higher the MAPLE score, the higher the rates of caregiver distress. So a high score on the thermometer for brain injury means pretty much the same thing as a high score on the thermometer for somebody without brain injury, without any neurological condition. So you can be confident that the MAPLE algorithm applies to the neurological population and neurological subpopulation just like it does in the general population. It is sort of interesting that you do see a little bit of an uptick that, if you look at the very high group, there's about another 5% increase in the rates of caregiver distress. Normally I'd say, well, that's statistical noise, but it's based on a sample of 400,000 people. So the confidence limits will be pretty tight around that. Yeah.
Are these MAPLE scores for both the community and long-term care setting?
These are only the home care clients
Only the home
in
care.
this case. Yeah.
Oh, yeah.
Yeah. Yeah. Now, what may be going through your mind is you may have heard about the RISE score. The RISE score is something developed out of the Northwest CCAC that combines the MAPLE algorithm plus something called the CHESS scale, which is a measure of medical complexity. I would not recommend doing that. I would keep them as separate measures because medical complexity doesn't predict caregiver distress and nursing home admission the same way as the other things do. I would keep them as separate indicators. It's sort of like adding up BMI and a thermometer score into one score. It doesn't really make sense to do the two together. The next kind of analysis that we did is around cost. What does it cost to provide services to these folks? So this looks at home care clients in Ontario. This is a 2009 analysis that we did, looking at the billed costs that go to CCACs on a per week basis and the shadow cost of informal care time. So what we did is we took the estimated hours of informal care provided by family members as reported in the RAI-HC. We weighted that as $10 an hour. So we looked at 50% of the cost of a PSW. We didn't weight it to what the discipline is of the caregiver. So you're not, okay, Hirdes is a professor at the University of Waterloo, so it's X dollars, and this guy works at Tim Hortons, so it's Y dollars. No, you're related to a home care equivalent person, a PSW is the marker. We shadow cost it to 50% of the cost initially, because you're also doing other things. You're making a meal for your relative, but you're also making a meal for yourself. You may be a little less efficient than a PSW may be. So, looking at 50% seemed like a reasonable estimate. We did sensitivity analysis to see that your conclusions change. They don't. So, it seemed to be a reasonable way to estimate cost. So if you look at people who don't have any of these neurological conditions and don't have stroke, you're spending about $130 a week that combine formal and informal care costs. If you look at people who have any of these neurological conditions, it's about $180 a week. But then if you look at specific neurological conditions, the costs go from a little bit lower than the overall neurological, but still more than the general population, about $160 for epilepsy, and almost $400 a week for ALS patients. So different diagnostic groups have very different experiences in terms of their costs of care. And so we need to sort of think about, what's the model, what's the optimal model for providing services to these different subgroups. The ALS population are an interesting group because I've seen a lot of pressure in the media about CCACs providing more support services to folks with ALS. They tend to be younger than the average nursing home resident, and so folks folks with ALS want to stay in home as long as possible. But they've got very high needs because it's such a severe condition. In fact, their needs are so complex that they don't do well in nursing homes. Nursing homes tend not to have the resources for them. So when we look at our data, it tends to either be in the CCAC system or complex continuing care, not in long-term care. So is there something in long-term care that can be changed to make it a more appropriate venue for folks with ALS? And could we provide good quality care in that setting? Or is this a group that we just know where it's going to be very expensive to provide services in community context? But my main point in showing this is that neurological conditions don't mean fixed costs. There's real differences across the sector.
In terms of breaking out the home first clients that the province is seeing, is there any work being done in terms of what proportion of those are impacted by these neurological or versus other conditions?
With the data cut I get, I don't have an easy identifier that says they are home first clients or not. We can do some of that to look at, did they come from a hospital setting and went home and then later on entered long-term care, but I don't have there's not a home first identifier in the HCRS data set. So that's one of the things that, from the OACCAC's point of view, you want to be sure that there are organizational identifiers like that to differentiate folks. The last point about this is that so far everything I've shown you is based on the data that we get on a sector-by-sector basis at the University of Waterloo, and they're all non-linked data. We do have a data request that's about to be fulfilled by CIHI that gave everybody in CIHI a heart attack. It's the biggest data request they've ever gotten, apparently, and we've managed to get it through. We'll look from 2003 to 2010. Everybody who's ever gotten a RAI 2.0, RAI home care, or interRAI mental health assessment anywhere in Canada, those data will be linked across settings, and they'll be linked to the National Rehab Reporting System, the DAD, and the NACR, so we can look at these people longitudinally. So it'll be an incredible data set to look at, because we can make all the uses of the hospital data, but have the richness of the clinical data from the interRAI instrument, and get this true longitudinal view across multiple sectors.
In terms, ISIS has all these databases as well.
For Ontario, but not for Canada.
Oh, that's right.
So any other questions on the neurological side of things? I hope you can see that you can name your subpopulation. We can do these kinds of things on a subpopulation if you're interested. All right, let's move on to palliative care. So we've gone from a project that's basically done to a new project that's underway to a new initiative that has no funding attached to it, but it's being rolled out in Ontario today. That's the implementation of the interRAI palliative care. One of the jargon things to get used to is that when you talk about the RAI, you're generally talking about the older instruments. So the RAI Home Care and the RAI 2.0 are the old generation nursing home and home care instruments. All the new instruments that are part of an integrated suite are the interRAI whatever, so interRAI palliative care, interRAI home care are all the new versions. We've redesigned those instruments so that there's identical items across settings rather than items that can be crosswalked. So get yourself used to saying interRAI palliative care and interRAI CHA, not RAI CHA and not RAI PC, because these are part of the new suite. And where we ultimately want home care to move is to the new interRAI home care to be compatible with that new suite of instruments. So that's what our the palliative care instrument looks like. I understand training is well underway. We finished that instrument in 2008. It's compatible with all the new suite standards. It's backwardly compatible with the RAI HC. There's two versions of it. There's a full version you would use in the general palliative population, and there's a shorter hospice version that you would use with people that are actively dying, but maybe within the last 6 weeks of life, and it starts to focus more on the immediate clinical issues as you get closer to death. There's not a Canadian-French translation available for this yet. One of the challenges with the palliative instrument is that, unlike the home care, nursing home, and mental health instruments, CAI does not have a reporting system and does not foresee having a reporting system for some time. So the OACCAC will be the main data repository for the palliative instrument for some time. So there'll be some less supports to the sector than we were able to enjoy previously with ones that CAI could support. And CAI is going to go through some tough times as the federal government reviews its allocations to Health Canada, which funds CAI. So I would expect that the next 5 years, it'll be OACCAC working together with interRAI to support the palliative instrument in terms of a data source. There are new CAPs coming. We've just finished the work developing the care planning protocols, but they're not available in a manual like this. It'll take another 3 to 4 months before they're available. And we're doing work on all the other applications around outcome, case mix, and quality, and I'll show you some examples of that. So we've had about a 4-year effort to develop the care planning protocols for the palliative instrument, and those are the 8 domain areas that we're focusing on. There what we're saying are the priority areas for clinical intervention. Doesn't mean that that's all you do in palliative care, but those are the ones that palliative clinicians said were the big issues that you've got to address in good quality palliative care. One of the things that we did that's sort of typical what interRAI does, as we got close to having those palliative protocols finished, we ran a workshop in Toronto sponsored by CAI and the Home Care Research Chair Network to review the CAPs, get feedback, make modifications prior to them being finalized by the interRAI group. So the triggering rates for the Ontario palliative data that we had from early implementation is that about 3/4 of the population triggers 2 or more of those care planning protocols. So only about 25% just trigger none or just one of those protocols. This is a fairly complicated population. On the other hand, only about 10% are triggering 5 or more out of the 8. So fatigue is the most commonly triggered protocol, whereas pressure ulcers and delirium are least common. In part, this reflects the population of palliative clients that we're serving in Ontario. The community-based palliative clients have a larger than expected proportion of people expected to live 6 months or more that are in some ways like a heavier long-stay home care client. So many of their care planning needs in some ways represent some of the more medically complex long-stay clients. And so these issues are going to be very common, things like fatigue and shortness of breath and so on. Whereas delirium and pressure ulcers really start to kick in with those who are closer to the end of life. But in terms of a need analysis for palliative clients in home care, well, these are the rates of your needs in those 8 domain areas. If we look at proximity to death based on a subjective rating by the clinician, blue are people that are expected to live for more than 6 months. Red are people where death is imminent. Yellow is less than 6 weeks to live. And for most of these care planning protocols, you see the closer you get toward the end of the life, the higher the triggering rates, which makes sense. It isn't always true. So depressive symptoms are sort of interesting. It's almost curvilinear. They go up and up and up as you get closer to death, and then when death is imminent, the rates seem to go down. That might be a function of cognitive change, and it may also be a function of other things that are happening that are helping the person deal with end-of-life issues there. So there's something about proximity to death that means that there are different clinical needs. It's almost certainly going to be the case that proximity to death predicts resource needs. The tricky thing is, how do we predict that somebody's close to dying? I think we all know people who've been declared as having 3 months to live with cancer that turn out to live for 2 more years. And so how do we sort of refine that ability? Well, we started to do some preliminary work to look at risk indicators for mortality using the interRAI palliative care data. So this came from an early study we did with Hamilton CCAC with the first 500 cases with the interRAI palliative care that we were able to link to death data. And what we found is we could use the CHESS scale, which uses decline in ADL, decline in cognition, and about 6 different medical symptoms as well as an end-stage rating item, combined with things like fatigue, pressure ulcers, problems with ADL and hygiene, and cognitive performance to differentiate different risk groups from the lowest risk group to the highest risk group, who look like this in terms of the subjective rating. So if we look at people in the highest risk group, about half of them are rated as having death imminent compared to none of the ones that are the ones. So people who score very low on the chest, who don't tire easily, in that group, nobody was rated as having death imminent. Most of them were rated as having being expected to live longer than 6 months, whereas the people that scored high on this chest scale had problems with the hygiene and had cognitive impairment. About half of them were rated as having death imminent. So the clinical scale corresponds pretty well to the subjective appraisal by staff. But here's how it does in terms of survival prediction. This is starting at time 0, 100% alive, for the people who scored on the lowest end. So these are palliative clients who were this branch, low on chest and didn't tire easily. For those folks, after 90 days, about 25% still died. So there's something about them as palliative clients that meant they have a higher mortality experience. But for these folks who scored high in chest, high in ADL, and moderate to high in cognition, about 80% were dead in 90 days. And in fact, we could pretty nicely differentiate these populations in terms of their mortality risk. So it gives us a clinical indicator that may be useful in helping with refined prognosis. It's also going to be something that's useful as a risk adjuster. If you're going to do quality comparisons on palliative care, it could be useful for saying when you trigger the shorter hospice version versus the full version. And it may be a useful predictor for cost. If you can sort of predict clinical characteristics that put you closer to death, they may be also predictive of higher costs. The next one looks at our first kick at thinking about a case mix system. So we looked at people in the long-stay home care client population who we knew died or had end-stage disease on the RAI-HC. And we looked at predicting the weekly formal and informal costs. We found physical disability, IADL impairment, cognition, chest again, declines in ADL, cancer diagnosis, and nutrition turn out to be predictive factors differentiating cost. The lowest cost group costs $160 a week. Highest cost group costs $1,200 a week. So just with these limited number of variables, we could explain about 42% of variance in costs of people who ended up dying. So it suggests, this isn't the final case mix system by any means, but it suggests we can use clinical characteristics to predict costs of people who end up dying in community-based settings. This is some work we're doing now with the Hamilton CCAC, where we're looking at costs for people who died and looked at what their costs were 12 weeks before they died, all the way up to their cost the week before they died. And the costs rise on average from about $150 a week, which is like what we saw in the general home care population, to peaking at around $450 a week. So proximity to death does matter. And it suggests that there may well be some opportunity to use some of these clinical indicators to start to predict resource use in a standardized way in the palliative setting. I'll stop there for questions around the palliative care industry. Question?
We adopt
Well, the only CCAC is doing all the implementation and education. We went for about 5 years with 3 or 4 CCACs partnering with us mainly doing it paper-based, which is a horrible way to do it. It's got to be automated. But OACCAC just told me that they expect 9 CCACs to be trained by January. And so, then it'll, the last 5 will have to happen sometime after that. But, my guess is that in 2 years we'll have, 100,000 observations in palliative care to talk about, so we'll start to look at that sector. And what starts to become exciting is, one of the challenges with palliative care is that it tends to be cancer care. There's lots of people who die who don't have cancer and don't get palliative care. And because we now have common instrumentation between the long-stay side of home care and the palliative side, we start to think about, are there some folks in the long-stay home care client population who look just like palliative clients who could benefit from more palliative services for that population, and maybe sort of get some better system things happening between those two parts of the community sector. And also, I think, with the hospice settings and palliative beds and complex continuum care.
So is there any uptake in hospice settings?
Hospices have got sort of an interesting problem because for some reason, hospices are classified, at least in some parts of the province, as community support services. So they're actually moving toward the CHOP, which doesn't make sense. They should be using the interRAI palliative care. But because they got labeled as CSS in the sector, the CHOP was what got mandated for them, and that doesn't make sense. So I'm trying to redirect folks a bit to say, the interRAI PC makes
That is a topic of conversation.
Yeah, the interRAI PC makes a lot more sense. Betty?
It should be, easily done because a lot of them is flow through money from the CCAC, so it should be easily done.
A lot of this is the day hospice, visiting hospice programs.
Oh, the visiting hospice.
Yeah, yeah.
Yeah. The other thing that's interesting about that is it leads to interesting policy decisions because the anti-fatigue treatment typically has not been on a prescribed drug formulary, and or it's very expensive at a cost about $5,000 a month, depending on what it is. So interesting policy decisions, I think, for government when they look at things like that.
Yeah.
A lot of people say, well, you're dying, you should be tired. Well, that's not the way people should think today. It's you can have a better quality of life. So I think that information is really interesting for policy.
Well, and the other one is, remember we had an earlier conversation about mood. The rates of triggering the mood cap are similar to what we saw in the long-stay home care clients, around 33%. I had somebody who was a major sort of opinion leader in Ontario about 5 years ago say when we showed the results around depression and palliative care, said, well, of course they're depressed, they're dying. Sort of gave us a sense of normalization of depressive symptoms. And depression does not have to happen at the end of life. Yes, there are very sad moments at the end of life, but clinical depression is something that's treatable and should be treated. Gary?
A couple of weeks ago, one of your colleagues, Trevor, stood in for you and gave us a presentation, and you showed with the increase of stress for the caregiver,
Yeah.
for the patient, when it spiked,
Yep.
the proximity of death, just that window closed
Yeah.
really quickly
Yeah.
as an indicator. It was
Yeah.
quite interesting.
Yeah, and we see that in multiple settings, that depression in the client is very strongly linked to depression in the caregiver. That's why I said depression is an infectious disease. It makes it just that much harder to be a caregiver. Yeah.
Oh, I was just going to mention that our staff here have been part of that paper ride for the past 5 years or so, and they're really thrilled to get on board with the electronic copy. What I see is a really a good fit is the hospice. I did work at the hospice, and it would be nice to see it match with the application process. So, the eligibility is 3 months or less, so to see it work with that would be, I think, a real positive, because they are doing the paper palliative for the application.
Okay.
So that's for the residential hospice.
Residential.
Yes.
All right. One of the things that we're on the lookout for is people who've got an interest in palliative research. The home care research community is small, the palliative care research community is tiny. And we need more horsepower in the Canadian context of people doing palliative research, because it's just such a massive area to do work in that we're really interested in reaching out to folks. So if there are folks that you know of in the Erie St. Clair LHIN that are either established researchers or want to do research in this area, send them our way. We want to collaborate with them. Any other questions or comments on the palliative side? Yeah.
How much of, because it's the interRAI, how much of it is actually available through some of the other tools?
There's probably for the palliative instrument about 2/3 overlap. So when we did this effort to create the new suite, we took every item that ever appeared on any interRAI form anywhere, whether it was experimental or actually used, and worked item by item through them. So we looked at 2,500 different variations of items, and we broke it down into 4 groups. We call core items that have to appear in all instruments. So cognitive skills for decision making and pain frequency and intensity are core that appear in every one of our instruments. Others were optional that were recommended but not necessarily mandatory for every interRAI instrument. Others were specialized, so there's some palliative items that you only see in the palliative instrument. There's lots of mental health items that are only in the psychiatry instruments. And then there are items that we just said, we never want to see these items anywhere in any instrument ever again. They were gone. And so the core items are, in most instruments, about half to 2/3 are from that core set.
Fatigue and dyspnea is not the core set, right?
In the interRAI HC, the fatigue and dyspnea items are the same, yeah. So, I mean, that's, the good thing is that the RAI HC was 3 years out from the effort to create the new suite. So, a lot of those items persisted there, whereas the RAI 2.0 is 10 years out. And, we need to find a way to move to the interRAI long-term care facility instrument. And we're kind of at a stagnation point that, CAI can't support until a province moves ahead and so on. And it's the instrument that's the biggest outlier from the suite. Any other questions before we move on to the next topic? So the next topic, this is the sort of final research topic, is something that is not funded, there's no research happening, and it's critical that we do this. And this comes from an experience that we had in interRAI that sort of shows how sometimes research happens as a result of personal experience rather than, sort of how we think scientists work. I mean, sometimes people think, researchers sit in their office, try to think about the next big research question, do 2 years of systematic literature reviews, boil it all together and say, we need to look at the relationship between graying of hair and aging. There's got to be something involved in that relationship. Sometimes it happens in much more interesting and rapid ways, and that's what this story is about. And it's around how we can use these instruments for emergency management, both preparing for emergencies, responding to emergencies. What I don't want you to think of is, because the example I'm going to show you is an emergency that's not going to happen anytime quickly in Southern Ontario, that doesn't apply here, because we look back in the last year, in Erie St. Clair, we had a snowstorm in December, as you remember, where we had 6 days of people stranded on the 403. And my parents live in Grand Bend, so they were stranded at home. Nobody could get out of London for a while. That's an emergency. And think about if we had an emergency in Corona with all the plants that are there. Things can happen very quickly. So we may have different kinds of emergencies in Southern Ontario, but we have real emergencies that we need to be able to deal with. Goderich is another great example. Absolutely. So to start up this discussion, I want to think about the way the RAI HC has been implemented in Canada, and particularly in Ontario. First of all, there's been a ton of research done to show that it's reliable and valid. interRAI has done 20 years of work in this area, so we know that the instruments themselves work. They're very clinically relevant. We designed them to be used by clinicians to support care planning and outcome measurement. The people doing the interRAI assessments in your LHIN are trained professionals who know what they're doing. Generally, the data are recorded on automated systems with good backup. Palliative care not right now, but the RAI HC, the RAI 2.0, the mental health, they go on computers. The computers are backed up, and they're pretty robust systems. And everybody that's covered by the mandate gets the assessment done. So there's around 165,000 Ontario CCAC clients that are assessed. And this is happening on a live and real-time basis. So people are doing assessments every day. The database gets updated on a regular basis. And for you guys, you can know the name of the person, their address. Some places are geocoding it. I don't get that because the data cut that I get is totally de-identified for privacy reasons. But this is something that should be true. If it's not true in your organization, you have to make it true, that the data are fully identifiable and exportable, that you can output this information. We do have a pretty regular reassessment cycle that's happening across the country, but that's where one of the things we're sort of underachieving. Sometimes provinces are waiting too long, and there's some delay in when reassessments are happening. It's critical that these reassessments happen to update the clinical information so it remains relevant. And we have a national reporting system managed by CAHA. So this is a pretty attractive scenario in terms of the IT part of how the RAI-HC is managed. So here's some examples of recent Canadian emergencies, the ice storms, the floods, and so on. If you don't know Ken Rockwood, he's a very interesting geriatrician in Nova Scotia. He was talking about Hurricane Juan, where they were getting ready for the emergency, the hurricane coming, and so everybody was ready in the emergency department to handle all the people that were going to be hit by trees or blown off the cliffs in Hurricane Juan. And the way he describes it is that they were waiting for the aftermath of this, and all these confused old people kept coming into the emergency. They kept saying, "Get out of my way, get out of my way, I'm waiting for the emergency to happen." The confused old people were the emergency. But they were the ones who weren't coping with it, and they were coming for the emergency for help. And they were looking for a guy with a tree limb stuck through his head and ignoring the elderly person with delirium. So, for me, the story began with the heat wave in France in 2003. This was a big heat wave. France had 40-degree temperatures for a week, and about 1,500 people died in Paris. Most of those were elderly people. And when we looked at the risk factors for dying, it was the people that were living alone, people who couldn't walk around, people with premorbid conditions, and people with bad insulation in their housing. And in 2003, I kept thinking to myself, could we have done something in the interRAI context? Could we have made a difference there? Well, then that takes us to February of this year. I was away on a ski vacation with my family, and an earthquake happens in Christchurch, New Zealand. At the time, 123 people were reported to have died, and Christchurch was pretty devastated. I don't know if any of you had a chance to be in Christchurch. It's a beautiful city, and I had the opportunity to be there about 3-4 years ago. And it's one of the few places in the world that I said I could live here instead of Canada. Generally, I don't say that. Christchurch was one of those towns. The challenge was that within the interRAI group, we've been functioning as a network of researchers for about 20 years. And so you have a lot of people that are colleagues around the world, but those colleagues become friends. And so when something happens in part of the world, you start to worry about your friends and how they're doing. Well, in Christchurch, there were 4 people there that I was worrying about while I was away on my ski vacation. Bridget Meehan was the person who was in charge of the national implementation of the RAI Home Care and interRAI Contact Assessment. She was in Wellington in New Zealand. Nigel Miller is the Chief Medical Officer in Canterbury Health District. That's where Christchurch is. So he was the guy in charge of dealing with the response. He was right in the middle of it. Vince Moore is a colleague of ours from Brown University. He was on sabbatical, and it's supposed to be flying to Christchurch that day. And then this guy was the head of IT systems for the RAI-HC in New Zealand. And you can't see his hat with the goofy ears down. The New Zealand Sun Safety that's well ahead of us, and he's modeling it properly for his baby daughter. So here I was worrying about my 4 friends that were in the middle of this. So what I'm going to show you now is a series of emails that got exchanged between us, in part to sort of show you that sometimes work is also personal, but also I want you to pay attention to the timeline and what happened in this series of interchanges. So about 9 o'clock that night, I sent a note to the 4 of them saying, I just saw the footage of the earthquake, and I hope you guys are okay. And this happens all the time with our group. Bridget responds, I haven't heard from Nigel, but I expect he's going to be very busy given his role. My family are okay, but quite distressed. Her son lived in Christchurch. The house was badly damaged, but he was okay. Vince said, we're fine, we're not in Christchurch yet, so I'm not going to go. I've not heard from Nigel, but I expect I will soon. By 1:30 that night, that morning, after I guess about 5 hours or so. Nigel responds, Jan and I and the family are okay, but it's not good here. 40 minutes later, Vince responds, take care of yourself and good luck as you struggle to help your city and its people recover. And then at about 4:30 that morning, Nigel sort of makes the joke, say, sorry, we're going to miss you because you're not coming to Christchurch. I'm thinking about an interRAI earthquake assessment. And sometimes, you know, we have gallows humor as things get tough. And when he said that, I thought back to the France earthquake and what the risk factors were for it. So that was 4:30 in the morning our time. 7 o'clock in the morning, I'm awake, and I send him a note to say, well, if you've already rolled out the RAI-HC in Christchurch fully, and you're able to get person-level outputs of the data, you should be able to create a list of people who are vulnerable who might need some extra help at this point. Bridget emails back at 5 o'clock, because they're asleep at this point, and the opposite end of the world. She said, it's a great idea, be helpful, I'm sure. I've spoken to Andrew, the IT guy, and he's going to pull the data this morning to send to Canterbury. So an hour later, I sent an algorithm, a back of the napkin algorithm of who to target in Christchurch in the earthquake. And Vince looked at my algorithm and said, add diabetes in very advanced stage, it's a good idea. And he said, I suggested we do this during Hurricane Katrina, but nobody listened to me. Andrew, the IT guy, a couple hours later said, Nigel and the Canterbury response team now have a copy of the list of vulnerable seniors. What a great international effort, and one based on real-life, up-to-date, accurate data. So within 24 hours, we went from having nothing to having a list of vulnerable people in the hands of the emergency response team of who to target. So here's the back of the napkin algorithm for the New Zealand earthquake. Thinking back to the France heat wave, we thought about, well, who's isolated and who's in trouble, who's vulnerable as the two target populations. And what we wanted to do here is to say these people are a priority even if their house wasn't damaged. So this wasn't about find the building that's collapsed and pull the person out. It's find the people that aren't in the building that you're already visiting because it's collapsed and who's in trouble there. So isolated from the RAI home care was, do they live alone, or are they alone for long periods of the time, or do they have no primary helper, as indicators of objective isolation. But there's also people who, because of depression or negative symptoms related to schizophrenia, might have withdrawn from activities or have reduced social interaction that nobody knows they're missing. Then there's also people that aren't alone, but their caregivers are in trouble. So their caregivers were already distressed before the earthquake happened, or there's conflict in the family. People are fighting, and so there may be a named caregiver, but the conflict may mean that they're not following up. Then we want to look at, well, what's vulnerable, and we thought about different ways of identifying vulnerable. There are people who are moderate or more severely cognitively impaired that we won't be able to comprehend what's happened to them. Or the people who've got a high chest score. They're already on the edge in terms of frailty, medical instability. They've got trouble seeing, so they've got trouble seeing. Now they've got to get around rubble, and they've got to get around a town that's dark or a home that's dark. They already have physical disability, or somebody was helping them with transfer or locomotion or toilet use, or they couldn't manage their meals or manage their meds. Then Vince said, add diabetes and add advanced age to that list, and he's happy. So that was the targeting system that they were able to, within 24 hours, output that list and give it to the emergency responders to follow up with those people. Aside from that, we were also able to use the interRAI assessments to manage the transfer. So for 300 people, their nursing homes were no longer safe. They weren't demolished by the earthquake, but they had to be moved because there were enough cracks that it was going to come down. So they had to find a way to move these folks. So what we did with those folks is everybody that was transferred, the RAI-HC or the RAI 2.0 for nursing homes was abstracted, and a package went to say, this is Edith, here's her RAI-HC assessment, and by the way, she doesn't like broccoli. And so it was part of the package that went so that the place receiving her as a client could see clinically what her last assessment said she needed and what her care plan already was based on that previous assessment. So what we ended up with virtually overnight was a multi-pronged strategy for emergency response. We were able to target people that needed immediate follow-up. We were able to also identify a medium risk group of people to watch out for. I did some work looking at institutional relocation in the elderly and found that there's a medium risk group that actually have spikes in mortality after move to new hospital, and there's no reason to believe that this would be any different. So it's not, you don't just keep your eye on the most vulnerable people, there are these other people that are in the gray zone. We supported continuity of care by helping transfer people with the complete care planning protocols. And we've also talked, we didn't use it there, but in the future, about using the interRAI acute care as part of the clinical management of evacuees. So there's lots of evidence in the disaster literature that very bad things happen in these tents that people that are in a disaster zone were in. Young people tend to leave because they're robust enough to get better, and they tend to be left with mainly elderly people that are very hard to manage. And they're folks that are really trained in emergency medicine that aren't necessarily trained in geriatric medicine. This is a way of bringing in geriatric medicine into the emergency tent to help the elderly people in those settings get better faster as well as on the vehicles evacuating folks. So the other part was the management of the evacuation process of deciding who to move, when, and where. So Vince Moore did some work looking at the Hurricane Katrina data to sort of show what's the cost-benefit trade-off you got to make in terms of when you evacuate people or not. He showed that living through Hurricane Katrina had the same impact on mortality as congestive heart failure does, after you control for all other things. In New Zealand, what happened is that when they were going to evacuate those elderly people, the military was in charge. They had two planes, a military Hercules transport plane and a commercial airliner. They were going to evacuate two populations, frail elderly people from nursing homes and home care clients, and then foreign nationals. And they were going to put the foreign nationals in the commercial plane. Bridget took the RAI-HC data and said, look at what these people look like. They were very frail. They're not going to survive this if you put them on that Hercules transport. Military switched the plane. The other thing we can use it for is for post-emergency evaluation to figure out what helped and what didn't help. And so Vince has done a number of papers on Hurricane Katrina. This got a lot of coverage in New Zealand afterwards. The Minister of Health in New Zealand stood up in Parliament and thanked the interRAI publicly for us contributing to the help in response to that. And what this shows for us is that this is a whole new application we hadn't thought of for interRAI instruments. So that diagram with the 4 applications now has to become 5. That emergency management is a major new application for us to think about. And it's especially important for countries that have already done the work to put the information structure in place. We don't have to introduce the RAI-HC in Ontario anymore. It's done. So 85% of the work we need to do to be able to use this as an emergency response system, it's done. And so we have no excuse for not benefiting from this. So we're working with World Health Organization on a collaborative effort to start to apply this emergency response system. The follow-up to it was this summer when the heat wave happened in Ontario. Again, I was driving into town and heard about the heat emergency, so we created a sort of a quick and dirty heat algorithm that looked at a combination of living alone, not getting out of the house, and looking at problems with heating or cooling in the home. We had 3 CCACs that pilot tested it quickly, and they all reported that it actually was helpful. One of the things that was good about it is that we look at the Hamilton experience. That heat algorithm identified for them 29 people to follow up with. It didn't give you 5,000. If it said 5,000, you would have never been able to do it. But they could say, okay, these are the 29 I've got to worry about this morning, and could follow up with those people immediately. Doesn't mean that this algorithm is right. We can refine this much further to get it right, but it shows that we can mobilize these data pretty quickly. The 2 benefits, the secondary benefits for this was, first of all, if we could make the argument before that interRAI assessments were cost effective because you could use them for 4 applications, you can now use them for 5 for the same price. It's even more evidence of cost effectiveness. But the critical thing that came out of this from the New Zealand experience is the nurses and doctors started saying, this really showed to me why it's so important that I get this assessment right. Their buy-in to the clinical value of the assessment went way up because they realized they could use it during the biggest national emergency that they had. So for us, in the Canadian context, we've got 8 provinces and territories that have got this in place, and we know that this can help. I don't want to end up in a situation where a big disaster happens in Canada, and I have to say to myself, we didn't do this. When, you know, it really isn't going to take that much work to make this a viable system for Canadians to benefit. Any questions or comments on this one?
Thank God for the internet to allow for that international collaboration.
Yeah.
And thinking too, right? And get to react.
Well, and what may be going through your mind is what about Japan? And in Japan, we have a lot of research going on, but they never mandated it. So that was a critical part, is that it wasn't available for everybody. And whereas in New Zealand, it was mandated. And that's what's great about Ontario. Because it's mandated, it covers everybody. Now in Katrina, it was a different situation. The OASIS system has been in place for some time and provides similar coverage. But the implementation there is that the home care agencies couldn't export the data. It was more of a black box, so they didn't have that capability. But more importantly, they didn't want to because they saw it as competitive information that they didn't want to release to their competitors. So they were sat on it anyway. And so here we've got, you know, all the right ingredients that we could be benefiting from this. Yeah.
Ralph Ganters chairs some of our emergency preparedness, and he just had a half-hour teleconference he had to step out for, John. So,
oh, you missed it all.
But it's nice. This is like a little bonus that we have to your presentation here, and I know I think that December 16th snowstorm that hit the 402 and came down near to the 401, and the August 23rd Godrich. I mean, those are in southwestern in our area, and they're in rural, so they won't get the attention. But can that have relevance for those areas that are smaller?
Absolutely, because it doesn't matter what the disaster is. The concept is that there are people who can't manage some major environmental challenge, whether it's you know, a snowstorm, a tornado, an explosion at a plant, a power outage. There's going to be, you know, most of us will do fine with that. We'll figure out a way to deal with it. But it's the elderly person living alone that nobody's checking on. I mean, so many of those deaths in France were, you know, elderly people living alone that nobody went to check on them, or kids were away on vacation and didn't call back. It's just one of the saddest moments I've ever had when I sort of realized who it was that died there. It was these folks that are, nobody's watching out for them. Yeah.
Just I was thinking, you know, obviously from an emergency perspective, it's great to help us align and get the most vulnerable out. But I'm just trying to drill down and thinking, well, you know what, there's a lot of seasonality that we know that ebbs and flows. And so taking this theory and understanding to really get predictive, and so how do we manage the seasonality and the cycles in any given year using some of this data?
Well, part of it is why we've got to be sure the data are up to date. It's not acceptable to have a YHC that's 9 months out of date. That, you know, and if what we've got to do is to stratify by populations at greater risk, that's fine. I'm all for using something like MAPLE to say somebody who's a high MAPLE should be getting it every 3 months. Somebody who's a very low MAPLE, I can wait for a year. But you know, so if we think about clinical instability, those people we've got to have up-to-date information for. And then it just becomes thinking about the different ways that people are at risk in different kinds of environments. So, you know, this isn't about the immediate rescue effort. It's the people that you're not focusing on that are going to be as much trouble. It's the delirious elderly person coming into the emerge where the docs were looking for the guy with the tree branch in his head.
Yeah, just to that.
No, I'm
We use vulnerable plant lists as well, so in all of the various many emergencies or emergencies we've had, we use the RAI data, just the same way to create, and we contact the police and the emergency EMS to visit those clients with us or whatever it needs to be.
Well, and there's dribs and drabs of that kind of activity. So you know, when the propane plant blew up in Toronto, the CCACs actually did use the RAI-HC there. The thing is, it's not organized.
Yes.
And, you know, we're not talking about a $50 million effort to make this happen. It's probably something that, you know, $200,000 project internationally, we could get this absolutely right.
Exactly, it doesn't have the rigor right now that
Yeah.
would benefit from something
Yeah.
like that, for sure,
Yeah.
for sure, absolutely.
Now,
Okay, I think,
I actually had one last bit to sort of talk about the home care research chair. To sort of, you know, that sort of ends off where I sort of think we can be going from here. So I was funded about 4.5 years ago to be the Ontario Home Care Research and Knowledge Exchange Chair. So 80% of the reason I'm here is because of Betty and my long-standing many debts to her and her as a colleague that I come to help out anytime anyway. And 20% is because this is what I'm supposed to be doing as part of my job as the Home Care Research and Knowledge Exchange Chair, reaching out to people across the province and doing education around that. So if I was to sort of look back of what's happened in the last 4 years, a lot of good things have happened. In that 4 years, there's been a lot of people that were either established researchers, but more importantly, new young researchers that started to do home care research that weren't interested in that before. If you look at the health services literature in general, it's at least a 10-to-1 ratio of people doing hospital research compared to home care research. And so that's been very positive to see some of the younger people coming up doing research in home care. And this whole move toward compatible information systems in different sectors, I think it's been a huge step forward. And so before we started, we talked about reaching out to the general public to get them to understand what's happened. People don't understand how much better the home and community care systems in Ontario have become because of us putting in place these standardized assessment systems so that we have much better evidence. It's been a remarkable achievement for Ontario to do that. And there's some really interesting new IT solutions coming. So the integrated assessment record, I think, has some real promise. So doing longitudinal cross-sector linkage of interRAI data so that clinicians can see what this person's RAI mental health, interRAI palliative care, RAI home care, and RAI 2.0 more. I think that's a big step forward. I think there's a lot of potential in the integrated client care project to improve integration. I like what I'm seeing there in terms of thinking about different parts of the health system working together in terms of integration. And, you know, the ability for the Ontario Health Quality Council, HQO now, to do public reports on home care and long-term care is a major step forward. And so, you know, the day that George Zimmerman appeared on the front page of the Star with that elderly person having had that horrible pressure ulcer where he's photographed in tears, back then, pretty much all we had in terms of public reports for the long-term care sector was complaints. Complaint databases are a terrible source of information about quality. Now for home care and nursing homes and complex continuing care, we can do LHIN level comparisons, province level comparisons over time, and individual agency level comparison. That's huge steps forward in terms of accountability to the public. The public really doesn't understand how much progress has been made in that regard. If I was to look at what I'm worried about in terms of where we're heading forward, we've taken some real hits in terms of home care research. The aging at home evaluation effort actually was quite harmful because there was a call for proposals, lots of people applied to those proposals, and then the funding was cut. And so people that we were able to lure into doing home care research got burned, and that's bad. That's not easy to overcome. You know, researchers are a finicky lot. The Career Scientist Awards got cut. There were several people doing home care research that were funded career scientists. That funding was cut midway through. And whether it's me or not, it's not clear whether the home care chair itself will be renewed. It's been 5 years. It's on the table as something that may be renewed, but there's no guarantees. And it is something that leads to real capacity to do research. If I was to look at going back to my life as a regular professor, I'd say my research productivity will drop to about 25% of what I can do today. So it's a real change, whether it's me or some other individual. It's something that could be an important loss. I think we've still got a long way to go in terms of CCACs and provider agencies working together. It's gotten better, but there's still lots of issues from CCAC to CCAC where sometimes data are shared, collaboration happens, and sometimes it's Fort Knox or, you know, name your other fort and the raiders from outside, that there aren't as free communication sometimes between provider agencies and CCACs, long-term care homes and CCACs. So there's still work to be done there on the systems exchange side of things. And we've really got to make the most of what's happening on the community support sector side. With them implementing a compatible system, we've got to get this right from the beginning. We don't want to go 5 years and then say, well, we've got these same data systems, we really should figure out how to make this work together. We've got to get that right now. I see several CCACs that are doing good and interesting things, but it's not all of the CCACs. So I think, that's something we definitely have to address. So it's not technical, scientific, clinical issues of compatibility, it's really business processes about how home and community care works together. And then moving to these new caps, there's been, in my mind, an inexplicable delay. We're using the old care planning protocols still in the CCAC system. This research was done 3 years ago. There's no reason we shouldn't have moved to the newer protocols, which are more focused, more predictive of adverse outcomes, and actually more cost effective because they're more tightly focused on people who are likely to be at risk. So those are some things in terms of how the system's working that I think we should think about. The other one is sort of an interesting transition that we've made. If this was 1996, where Betty and I were standing in the hallway commiserating, a lot of decision making in healthcare was based on gut feel. Here's what I think is really happening. And the introduction of various interRAI instruments has let us move toward an approach that's more evidence informed. That we can use information and say, well, here's what I see, and then in speaking with the person, here's a reasonable solution for that. That's been a huge change. To go from having no standardized information system to something that's like this can really help us to make important policy changes. But sometimes what you see is people switch into what I call data-driven thinking, where the algorithm becomes all-powerful, where because you get this score, this is the only thing that can happen to you. That's not evidence-informed decision-making at all. So it's always the case that the clinician uses an interRAI assessment just like a clinician would use a CAT scan, a thermometer, what have you, as something to inform their decision-making. And so what we don't want to have happen is what we saw in that Toronto Star series where somebody says, a case manager says, the computer says you're not eligible. That's horrible clinical practice. That's not what the interRAI instruments are about. And unfortunately, I do see this in the country that people are having a hard time making the switch from no data, no evidence, to using data to inform their decisions, whether it's laziness, lack of education, lack of motivation. Sometimes people say, oh, I don't have to think now, the computer will tell me what to do. We want to counteract that as much as I can. Now I'm done.